Okay. Okay, so we're ready to go. Oh, so good evening, everyone. Okay, so like I heard Frank say a second ago, the Hudson Valley Regional EMS put out this protocol, I think, either yesterday or the day before. I'm sure it's going to get changed because there's some inconsistencies in what the state is saying and what we've previously done and stuff like that. But for the meantime, this is what we have. So let's just go through it, and then we'll talk a little bit about the other things that we were going to talk about today. Okay? And today we're going to do a little review of shock and a little review of respiratory emergencies. That was what was decided. Okay, so the first thing is this talks about termination of cardiac arrest, which means that you've decided that this patient is workable, right? So if it's a situation where the patient is obviously dead or has an advanced directive, right? So let's go over those two different things. So the patient has an advanced directive, which for our purposes would be a New York State out-of-hospital DNR form, okay? Or a MOST form, medical orders for life-sustaining treatment. Those are the two advanced directives that we're allowed to honor in the field. If either one of those are present and properly signed and filled out, then we do not start resuscitation. Even if that person was conscious when you got there and died in front of you, if there's an advanced directive, you do not start resuscitation. If the family is arguing with you, then you would call medical control for direction on what to do. But if there's a properly filled out advanced directive, technically you cannot resuscitate that patient, even if the family wants you to. The only person who could rescind the advanced directive would be the patient, or if there's a healthcare proxy, the proxy. But the problem is that in the field, we can't honor a proxy because it requires a physician to declare the patient incompetent. And obviously we don't have a physician with us. So you could say, talk to the doctor and see what, talk to medical control and see what the medical control wants to do. So again, advanced directive, we do not start resuscitation. So this protocol that came out doesn't work for us because we wouldn't have even gotten to the point where we need to look at it. The other time we wouldn't even be looking at this is if we show up at a home and the patient is deceased, but they've been down for a period of time, say more than 15 or 20 minutes. Now, how we would tell that, and I'm sure everybody knows already, but just to review, is we would look for what's called dependent lividity. So dependent lividity means that we'd have to roll the patient. So the part of the body that's closest to the ground when we find a patient is the dependent part of the body. And lividity is the pooling of the blood. So it gives a blackish, bluish, purplish discolorization to the skin. So obviously it's much easier to see this on a Caucasian patient than it would be on a dark-skinned patient. So you would, roll the patient, remove some clothing, and look, and where you're going to see it if let's say they were supine on the floor, they're on their back. So where you would see it is in the small of their back and behind their thighs, behind their calves. You wouldn't see it too much on their buttocks, where their buttocks were pressing on the ground, or their shoulders, where their shoulders are pressing on the ground, because that pressure doesn't allow that much blood to get down to the skin, so it doesn't pool. Now, typically, dependent lividity, we say, starts somewhere 15 to 20 minutes. Obviously, it's dependent on the patient's otherwise medical condition, the temperature of the room, and everything like that. But say within 15 or 20 minutes of no blood being pumped, you're going to start seeing some dependent lividity. And if that's the case, the patient is beyond resuscitative efforts. That means nothing has circulated for at least 15 or 20 minutes. There's irreparable brain damage. You would not resuscitate that patient. Okay? The next stage, obviously, after that would be that they develop rigor mortis. And I'm sure everybody knows that the first place you develop rigor mortis is in the jaw. So either their jaw will be closed and you can't open it, or their mouth will be in an open position, you can't close it. And that obviously, could be anywhere again from, say, 30 minutes to an hour, probably an hour plus in most cases, where you would start seeing rigor mortis. And again, there would be no purpose in resuscitating those patients. So again, we don't even look at this protocol because we're not even going to consider working the patient if there's any type of advanced directive that's valid. And remember, advanced directives do not expire, even though it says it's supposed to be renewed every 90 days. They're still valid even if they haven't been renewed. But you do have to physically see it. You can't take somebody's, dying declaration, if there is one, or a family member swearing there is one. You have to physically see it. It has to be signed by the proper people. On the New York State out-of-hospital DNR, it's only signed by the physician. On the MOST form, it's signed by the patient or the guardian and the physician. And it does say all over it that it's supposed to be renewed, every 90 days, but they're typically not, and they're still valid. A copy is valid, and all that. And that if you start a resuscitation because one wasn't present, and so you start CPR, say, and the family then subsequently provides you with one, you would stop resuscitation. And I'm sure everybody knows the issues sometimes with the nursing homes, that they don't make them so readily available because they don't want to have the person left in the nursing home, because then it's a reportable incident that they have to report to the Department of Health, where for some reason, if we transport the patient, it's not reportable. So, so sometimes they kind of hide the DNR from us, but it's a very rare patient that's in a nursing home that doesn't have a DNR. So you just have to be a little forceful to get it from them. Okay, so if anybody has any questions, unmute yourself. But, I guess we'll get into this little protocol. Now, I sent it to, pretty much everybody at your ambulance corps who I had their email addresses for. So I'm sure that everybody will get it one way, shape, or form themselves. Like I said, it's probably going to be modified. And, as soon as they modify it, we'll send it out. Okay, so it says after 20 minutes of resuscitation, again, this is a patient that's workable. So after 20 minutes of resuscitation efforts, consider a decision based on one of the following. Okay, have you considered end-tidal CO2? So again, on a BLS level, at least now, there's probably nobody who has end-tidal CO2. That would be the measuring of the patient's exhaled CO2. Now, some of you may be saying, if the patient's not breathing, how are we going to measure that? But, if the patient's intubated, there's a device that clips between the endotracheal tube and the bag valve mask, and then it's read through the LifePak 15. So on a BLS level, there are devices that look like a pulse ox, but instead of having a probe that you put on a patient's finger, there's that same device, and the wire goes to the machine, and it would give you a number, and it would give you a waveform, showing you what's going on. And that's something obviously you would have to have some training in to interpret and stuff like that. So you're probably not going to be, using waveform capnography. Okay. Now, so it says whenever possible, termination resuscitation should be done when a patient is not in a public place. So that's pretty obvious. Especially if it's a crime scene and it's a supercharged, scene, like picture these things that are going on now. Somebody drops dead, the ambulance shows up, and they just say, we're not taking that patient. You got 1,000 people looking on. So, you already have a riot going on, and now you're sure to have a riot going on. But if that's the case, you're coming into a superheated situation, don't do anything at the scene. Just pick up that patient, make it look good, put them in the ambulance, and start transporting. And then if you decide, you're not going to do anything, that's a different story. But don't stay on the scene and do it, because no matter how good a job you're doing, you'll never be satisfying everybody there. Okay, so now we go down to say box number 1. Does the patient care team, that's us, right? Does everybody agree to terminate the resuscitative efforts? So if somebody disagrees, and that's something you're going to have to decide internally. Like some agencies may just say, the crew chief calls the shots and that's it. Or somebody may say that every, EMT on the call has a decision-making capability. By us, if there's 2 paramedics on the call, they have to both agree to terminate resuscitation. So do both agree? If no, then you continue efforts, okay? If not, then you have to go through this little checklist. Okay? So it says, does this patient meet all these requirements? So they have to be an adult, they have to be 18 years of age or older. The arrest had to be not witnessed by a bystander or EMS. No bystander administered CPR, no defibrillation, okay? No return of spontaneous circulation for 20 minutes, and at least 20 minutes of resuscitation has been provided. And we interpret that 20 minutes of resuscitation that it had to be a successful 20 minutes, which means that there had to be IV access, there had to be intubation or some type of advanced airway, there had to be the ability to defibrillate, there had to be medications being pushed if that was indicated. If they never get an IV, they have to transport that patient BLS.
Excuse me, Frank.
Mm-hmm. Yes.
Are we supposed to be seeing what you're seeing?
Yes, you don't see the.
No, we don't.
Oh,
no,
I asked.
We don't.
Okay, I'm sorry. I asked before, and somebody said yes, but
we did before, but something switched, and now it's all the people that we see.
Oh, okay. Let's give me a second. Let me see how we get that going. At least I know, Artie, that you were paying attention. Oh, that's not right. Where did it go? Let's see. Okay, here it is. Share screen. Is it there now?
Yes, it is.
Okay, I'm sorry. So let's go back let's go back up. Okay, so here's the start of it, right? So it says after 20 minutes of resuscitative efforts. Again, this is a patient that's workable, right? You can make a decision based on one of the following. So end-tidal CO2. So on an ALS level, hospital level, the measurement of end-tidal CO2 is really the I say definitive marker, which, you know, the physiology of the body is that if you have an intact airway, right, you have a good intubation and you have blood flow down, you know, a good blood pressure, good blood flow to the pulmonary capillaries that wrap around the alveoli, you should be generating CO2. Even if that person's heart is not beating, if you're doing good compressions, okay, and you have good ventilation, you should be generating a little carbon dioxide. So you're measuring with that machine the exhaled CO2, and there's numbers. You know, there's different numbers mean anything. Like right now, in us sitting here, we are exhaling 35 to 45 millimeters of of carbon dioxide, right? So in a cardiac arrest, you wouldn't expect to see that. We're pretty much happy with over 10. So if you saw a number of 10 on the end-tidal CO2, you would continue working that. But if the number never gets above 10 and you've been working for the patient for 20 minutes, they would say that would be a reason to terminate the code because it's not going well, it's not being successful. Okay? So that's where that comes in. Again, it's going to be a while before those end-tidal CO2 units for BLS agencies, you know, come down to a price that they're probably worth getting. They're still probably, you know, somewhere between $3,000 and $5,000 per unit. So, you know, you got 3-4 ambulances, you're talking a significant investment, and you're pretty much only going to be using it in cardiac arrest. Some of them have instead of a device that clips between the endotracheal tube and the bag valve mask, has a special kind of nasal cannula that has two hoses coming off of it. One hose goes to the oxygen tank, another hose goes to the device that monitors it, and you have the ability to administer oxygen at the same time that you have the ability to measure the exhaled CO2. So let's say, like later we're going to talk about asthma, and an asthmatic, okay, that would be a good device to know how well your treatment's going, right? If that patient is exhaling CO2 well, you know your treatment's going well. So that might be something, you know, down the road that will come to a cheaper price where, you know, it would be something that might be useful in areas where you don't have ALS coming with LifePak 15 and stuff like that. Okay, so after 20 minutes, if everybody on the team agrees that we're going to terminate this code because it's not going well, right, we go through these different decision-making capabilities. If anybody on the team says, no, I think we should continue working it, then technically you're supposed to continue trying to resuscitate that patient. So everybody agrees to terminate. Now you have to say, is the patient over 18 years of age? If not, you have to continue working it. Okay, is the arrest not witnessed by bystanders or EMS? You have to continue working it. No bystander administered CPR, so on, right? So I think you can see all those things now. If the answer to all of that was yes, then I'll just go down first and we'll talk about it. ALS can terminate without calling medical control. BLS has to call medical control and then get permission to terminate. My dealings with the hospitals here is that, you know, they're pretty quick to tell you to terminate, especially under the, you know, still under the COVID environment and stuff like that, that they're pretty quick to tell you to terminate things and stuff like that. So I wouldn't, you know, I wouldn't think you would meet any resistance if you explain what was going on, that you tried to resuscitate the patient and it's not going anywhere. Okay. If, let's say the patient is 17, okay, well, I don't know. Most people probably would continue working a younger patient. But let's say that there was bystander CPR, you know, ineffective bystander CPR. So technically, the answer now is no. So you can't just go down and call medical control. So it says, providers may consider termination resuscitation for these patients who do not meet the termination resuscitation standing order only with medical control approval, and if the family is amenable to that. So what that means is that, you know, in that situation that I gave where there was bystander CPR, you work them for 20 minutes, it's not going anywhere. You say to the family, look, you know, he hasn't been breathing for, you know, 20 minutes. He probably has irreparable brain damage. You know, what do you want us to do? Do you want us to continue trying, or do you want to just, you know, have us stop it now and let him be? And if they say, no, you know, we don't want him to be, you know, alive but brain dead in a nursing home, then you would call medical control and say, you know, we were working a patient for 20 minutes. It's not going anywhere. The family is fine with withholding resuscitation. Can we? And if that's the case, if that medical control gives you permission, okay, then you would, you know, I'm sure in most of your areas the police are there already, but if not, you would call the police. they would then get in contact with the medical examiner's office. But at this point, you're done, right? I would complete a PCR. Those of you who are doing electronic, the issue is that usually the medical examiner is going to want a copy of the PCR, so you'd have to figure out how you're going to get it to them. Okay. Medical control would agree with your decision to terminate. They could say no, continue efforts. Okay. Or, now this is one of the things that was a little unclear. So continue efforts would mean stay on the scene and continue efforts, which again would be kind of silly. Like if they tell you, we'll work them for another 10 minutes, right? That would be continue efforts, but that's kind of silly. And then initiate transport would mean continue working them, but start transporting and working them en route. So that's that one. And if we go to the bottom here, this is where it gets a little hazy, I guess. So it says when resuscitative efforts will not be initiated, okay, or terminated once initiated, either through standing orders or online medical control, document as a termination of resuscitation. So, I think they just want that verbiage in there now. Most of the times, we document it as a code, and then we'll just say medical control contacted, decision made not to transport the patient. So it's kind of the same thing. And then it says indicate the time that resuscitative efforts have been withheld. So I do see here still sometimes people write patient pronounced at such and such a time. We are not legally allowed to pronounce. That is a licensed physician, nurse practitioner, or I believe a physician assistant also. Are only people are allowed to pronounce and sign a death certificate. So, some places don't allow PAs and some places don't allow nurse practitioners, and they require the doctor, like in my wife's practice, if the nurse practitioner is the one who pronounces the patient, the doctor still has to come and sign the death certificate. Okay? So, that's it. And again, the time that we decide to stop resuscitation may turn out to be the time of death. That's really totally dependent on, the medical examiner time they put as time of death. Okay? So pronouncement of death should not be made by the EMS provider. So you shouldn't say to the cops, we're pronouncing them dead. Like I have all the time the cops saying, what time are you pronouncing them dead? And they'll say, well, we don't really pronounce death, but we're going to stop working them right now. Okay. And then the other thing, it says, once transportation has been initiated, includes any point after which the patient has been moved from the place the patient was found, and a decision has been made to withhold resuscitative efforts. The patient is to be transported to the hospital emergency department. So to me, it sounds like we pick the patient up, we put them in the ambulance, okay, and now we decide not to do anything. So I don't know how that would quite happen, unless maybe it was that crime scene or something like that. But, what they're saying in that situation, you would have to transport them to the hospital. Now, I guess the area that I think that's going to be a little bit of a problem is you go to a nursing home and you take a patient who's alive, serious shape but alive, who has a DNR, and you start transport. Okay. En route, the patient goes into cardiac arrest. So we know that we don't work that patient because there's a DNR. What we're supposed to do up until this point was go back to the nursing home, and they were supposed to accept the patient. I'm not saying it was always easy, but they were supposed to accept the patient. According to this thing now, we would be transporting them to the hospital to be pronounced. So if that's what they want, that's fine. But at that point, you would not be transporting lights and sirens anymore. So you would just be transporting with, regular taxi cab type of transport, because that patient's not being resuscitated. Therefore, there's no emergency. Therefore, you don't have the right to go lights and sirens. Okay, so I see Nancy perked up as our legal expert. So what do we think?
I have a question.
I'm sure you do. I wouldn't think otherwise.
Has in all of these transitions between COVID and non-COVID, and we're back to normal and whatever else, has anything changed about a patient that's obvious death?
So right before you signed on, we talked about that a little bit. So obvious death is still, I shouldn't say this, patients that you would not work. That would be the first thing. So you will not work any patient who has a valid advance directive. So that's an out-of-hospital DNR, okay, or a MOST form. The other thing that I forgot to mention the first time, which is, let's say you decide to go get a community member in the hospital and bring them back to your community. I think some of you still do that, right? You'll go to a nursing home, bring a resident back to their home from your local hospital. So let's say that in the hospital, they have a in-hospital DNR. But for some reason, they don't have an out-of-hospital DNR. So the in-hospital DNR covers them up until the point that they get home. So in other words, the transport home is covered by it. But now that once they're home, if they call you back 10 minutes later after you leave, technically there is no more DNR. Okay. Now you could call medical control and say to them, listen, we just brought this guy home. They had an out-of-hospital DNR from your facility, and they coded, the family doesn't have a out-of-hospital DNR. They only had an in-hospital DNR, but they don't want us to do anything. Are you okay with that? And if they're okay with that, then you don't have to resuscitate the patient. So that's the first time where this other protocol that we're just looking at would never go into effect because you would never consider working the patient. And the other one is that they have signs of obvious death. So signs of obvious death would be a mortal injury, right? Their head's chopped off, they bled to death. It's a horrible accident. There's blood everywhere. There's, no chance they could be alive. Or that you find an unattended body, right? Nobody saw that patient collapse, or, they last saw the patient a half hour ago. And that's where I told you have to look for dependent lividity. Okay, so you want to look at the part of the body that's closest to the ground. Okay, you have to look at the skin. And if they're supine, we said it's going to be there underneath, behind their thighs and the small of their back. And you want to see a purplish discolorization of the blood pooling. Much more difficult in dark-skinned people, very easy in most Caucasians to see it. And if that is there, you would not resuscitate. If that is there, okay, there should be rigor mortis also. I'm sorry, if that is there, there may or may not be rigor mortis, depends how long they're down. But if there is rigor mortis, okay, there may not be dependent lividity. In other words, if they've been dead for, 8 hours and sometimes and stuff like that, the whole body may start looking dusky and it may be a little hard to pick out the dependent lividity. But if they have rigor mortis, they're also obviously dead, so you don't have to start resuscitation. Other than what we just described, then you would go to this protocol that we just looked at now, and this would go into effect. But I'm pretty sure there's going to be a modification to this.
If we find an obvious death, who then is responsible? What do we do?
The police department would be there because it's technically a crime scene until the medical examiner decides it's not a crime scene. Okay, so that you would then leave the deceased person with the police department, and that's it.
If they're there.
Well, you're stuck, right? Because I guess that's one of the issues we had here during COVID, which was the cops were not coming to calls with us. So we were leaving deceased people in the homes with their families pending the medical examiner coming. And sometimes there were 8-10 hour waits, with the dead people in the family's home. They were much more responsive to private homes than they were to nursing homes and assisted livings. We had people overnight, dead in assisted livings and nursing homes waiting for the medical examiner's office to come. So there was one weekend where they were, I can't even tell you how backed up they were. So, but that's basically where it is. On a more cheerful note, I think we've all seen the rate of COVID infections is dropping, and the virulence of the actual virus seems to be mutating towards becoming weaker. So most of the patients that are in the hospital that are sick are not as sick as they were, say, 3-4 weeks ago. So, and
Is that because they're getting better care? Because there are less people?
No, it's trust me, it's the virus. The virus is mutating. It's definitely getting weaker now. That doesn't mean that it can't mutate again and get stronger. So we shouldn't put our guard down, but it's definitely, it's definitely mutating. They're not saying that in the United States, like the CDC is not saying that, but like, other countries like Italy already is kind of saying that what they're seeing is a weaker version, and that's typical, and also we have some, somewhat some herd immunity right now, what they call, herd immunity, which is that a lot of us have been exposed to the virus. We may not have gotten it, but we may have developed antibodies to it. And don't worry if you had antibody tests and it says you don't have antibodies, because all those tests are garbage, to be honest with you. They're finding that, people take 3 different versions of the test, and one tells them they do have it, another one tells them they have a tiny bit, and the other one tells them they have a million of it. So I don't think any of those tests right now for titers are 100% accurate, But we've had people who've lived in the home, paramedics who have lived in the home, have been infected, have lived in the home with their wives in the same bed, not knowing they were infected, then got sick, and still lived in the house with them, and their wives and children do not show titers. So now how could that be? You know, coughing, hacking, touching, you know, in the same bed, and they don't have titers. Never mind, they didn't get infected, but they don't have titers. So I don't know how precise any of those. I know the Abbott test is supposedly garbage. You know, so that's the one that they were using in the White House, you know, when they were testing everybody daily, and then they said, you know, it wasn't accurate, and they had a couple people pop positive on a different test. So they're not using that one anymore. Okay, so any questions on the adult cardiac arrest, termination, or resuscitation? Okay. Any questions on anything before we get into, you know, our actual presentations for the night? Okay, so
No.
one thing I just wanted to talk about was the quiz. So I've gotten some minor feedback from one or two people in some of the agencies that the test is hard and the test has stuff on it that we did not necessarily review. And that is, the hardness may be correct. And the fact that it may be a material that we didn't necessarily review may be correct. So my concept is that, you know, everybody's getting 3 hours of CME, and I need to make sure you're doing 3 hours of work. So the lectures at the most are going an hour and a half, you know, maybe if I really talk about 2 hours. So, you know, we need to have some mechanism to show that you're actually doing it. So when you take that quiz, it actually takes track of how long, you know, you were doing it for. I mean, some of you pause it and it shows 7 days, which obviously, you know, it's not going to count. You're not going to get 7 days worth of CME, but, you know, at least it shows how long people have been in it. So, I mean, and most of this, everything that's on the test is stuff that you should know as an EMT, right? It's kind of, you know, common everyday EMT knowledge that you would be expected to know. Okay? And if you're really stuck, you got 3 choices. So the questions don't really change all that much. And, you know, eventually by trial and error, you'll get it right. Or if you really can't get it right, then just call me and I'd be happy to explain it to you and go over it with you. That's the purpose of, you know, why we're doing this stuff. Okay. Okay. So let's talk a little bit about some respiratory issues. I guess we'll pick on asthma, since that's usually what we see the most of and stuff like that. So we know that the asthma is a situation where your immune system becomes hypersensitive, okay, to certain situations. And it's really the immune system that kind of lives in your bronchioles, that part of it, that becomes hypersensitive. So it's kind of called a hypersensitive airway disease. And that there's certain triggers, there's certain things that overly stimulate your bronchioles to do a couple different things. So one is that they contract. So your bronchioles are aligned with smooth muscle, just like your blood vessels, just like your intestines and stuff like that. So they have the ability to dilate and constrict. So if you were running, they would dilate to let more air in, and they should very, very rarely constrict, right? There's really no reason for them to constrict. They will constrict a little bit if you're breathing cold air, just to minimize, like when you go out in the winter time, they do constrict a little bit just to minimize the amount of cold air you bring in and stuff. But for the most part, they shouldn't constrict. Now, obviously, when you're having an asthma attack, constriction is a big problem, okay? But that's not a normal response. The other thing that happens is that the lining of the bronchioles, okay, they start to constrict, and the mucus secreting cells start to produce more mucus. So mucus is a vital substance, right? We need mucus. Mucus is like a sticky substance that lines our entire airway, and the purpose of it is to catch things that should not be getting down into our lungs. And mucus is basically expelled upward because we have hair, cilia, it's called CILA. We have hair lining our airways, and that hair is actually waving back up towards our nose. So all that hair waving is actually moving the mucus up, okay, into our throat, where we swallow and eat it. The vast majority of your mucus you swallow and eat, which is why when you have a situation where you have a postnasal drip and stuff, sometimes you feel nauseous just because you're getting a lot of mucus, you know, down into your stomach and stuff like that. But the problem with asthma is that you could develop something called mucus plugging, okay? And you could also do it if you have cystic fibrosis, COPD. But mucus can get very gluey, very tight, like cement, okay? And what happens is that when somebody's breathing fast, okay, is that they tend to dry out their airways. And we know how that is and everything like that, okay? Also, when we give them oxygen, the way we give it to them out of our tanks, it has zero humidity in it. We also promote that drying of the mucus and that plugging of the mucus. So ideally, respiratory patients should have humidified oxygen administered to them. So you should have the disposable humidifiers that are pre-filled with sterile saline, that when you have a respiratory patient, you then put onto your onboard oxygen, not your portable, your onboard oxygen, and you administer oxygen that way through them. Now, obviously, humidified oxygen works best through a nasal cannula. It doesn't work very well through a non-rebreather. It doesn't work very well with CPAP, but it does work pretty good with a nasal cannula. And that should be the way you give it to all your respiratory patients, with the exception of the pulmonary edema patient who's obviously wet enough already. And you should be giving it to all your pediatric patients, especially your pediatric respiratory patients, because they dry out much quicker, right? And they would have bigger issues because they have tighter airways and stuff like that. So this is what mucus plugging looks like. Now, these were obviously people who it killed them, right? So this is dissected out bronchioles, okay? So if you look down here, they opened up the bronchiole, and what happened? So here's mucus that where it bifurcated. This is always called the saddle, like if you were sitting there and these were your legs. Okay, this is always, whenever you have a bifurcation like this, if something sticks here, it's always called a saddle embolism. But in this case, it's not really an embolism. It's just mucus that kind of clotted in there. The same thing over here, okay? And again, this patient obviously couldn't have survived, but this is what they yanked out of or dissected out of somebody's lung. This must have been a cystic fibrosis patient, I would assume, that this came out of. So this, in its case, this is basically what happened. The patient had an obstructed airway, a lower airway obstruction that could not be managed, right? There's no way to get that out of them in that situation. What they will do, like let's say this is an intubated patient, is they will squirt saline down the endotracheal tube, which makes the patient feel like they're drowning, and then they will suction it out, which obviously makes the patient feel like they're dying, like having a vacuum shoved down your throat while you're trying to breathe. And they do what's called tracheal toiletry, which is they, pull out all this crap out of their lungs. And once they get it out, they pink up, their O2 sats go up and they feel better. And depending on the condition, this may have to be done, every hour on these patients. So it's, this is one reason why you don't want to smoke. Okay. So again, different triggers for asthma. So we know allergies, infection, stress, temperature changes, like we're going to go into the season now, probably happening already this week. Where we'll start seeing people with the pollen and with the humidity and the temperature changes. Exercise in some people will do it, So there's all different types of triggers. People can have more than one trigger that causes them to have an asthma attack. And patients that are, have a history of known asthma should be carrying their rescue inhaler, which has albuterol in it. And they may be taking 1-2 times a day their maintenance inhalers, which are designed to prevent them from having an asthma attack. But their rescue inhaler is the only thing that will help them once they're actually having an asthma attack. So they don't have to carry their maintenance inhalers with them, but they do have to carry their albuterol rescue inhalers with them. Okay, so what are some different signs and symptoms of asthma? So the most classic sign of symptom, obviously, is difficulty breathing, right? Usually accompanied with wheezing. Now, wheezing is the sound that air traveling through your bronchioles. So your bronchioles are your lower part of your airway. What they call your terminal bronchioles, like the train terminal, the end of the train ride. So terminal bronchioles are small bronchioles that end in alveoli, an air sac. They spasm, and it's basically like when you whistle, that you're trying to blow air through a narrowed passageway, and it makes a whistling sound. So that's what wheezing is. Now, I don't know if anybody remembers, but there's always a test question that says, in an asthmatic, does wheezing start as an expiratory sound when they're breathing out, or an inspiratory sound? So most of the times in asthmatics, it starts as an expiratory sound. And the reason why is that when we breathe in, that's what they call the active stage of respirations. Because what's happening? Your chest is getting thrown out, right? And your diaphragm is going down. So it's active. Your muscles are contracting and pulling your chest wall out, making your diaphragm go back, go down. It's increasing the size of your thorax, which is lowering the pressure of your thorax less than the pressure in the atmospheric air. So it only needs to go a millimeter or two less than the pressure in the room, right? And then air will flow in, because it always, air like water goes from high pressure to low pressure. So that's considered active. When that air flows in, it actually opens up those narrow bronchioles and you don't get wheezing. But when you exhale, it's considered passive, because what happens? The muscles relax, the chest gets tighter, the pressure inside the chest therefore gets higher, and it forces that little bit of air that you have in your chest out. And that's where you get the whistling sound. So most of the times in asthma, it's a expiratory sound. If you hear what's called biphasic wheezing, that means they're wheezing on the way in and the way out. That's considered further into their asthma attack. And then I think we all know that if they stop wheezing, which means they're going to be unconscious probably, that they're at when what's called status asthmaticus, they're in a unbreakable asthma attack with their albuterol and they're going to die if we don't do something. And years ago on a BLS level, you didn't have anything to do for them. You could try ventilating them, but the bag valve mask is going to be useless because they're so tight. So, but now they've amended the New York State BLS protocol and the regional protocol to allow EMTs to use the Epi Pen or check and inject Epi, just like you would use it in anaphylaxis on a dying asthmatic. But the only caveat is that in anaphylaxis, you're allowed to administer it as a standing order because, you know, anaphylaxis is pretty clear cut and the only real treatment is Epi and it's a life-threatening intervention. In asthma, it's so rare that they get to status asthmaticus where they're tight that, you know, they want you to call medical control for permission to use it in that case, because it just really would be rare that you would ever have to give it. Before there was albuterol, all we ever did was give people epinephrine for asthma. We gave every asthmatic an injection of subcutaneous epinephrine, and they hated it, and they felt jittery and nervous and bouncing all over the place. Now, that is still possible with albuterol. It can make people feel nervous and jittery and tachycardic and stuff like that, but nowhere near the degree that epinephrine does. So what else? They tend to breathe fast. That's tachypnea. They get tachycardic, both from a compensatory standpoint and also because they're scared. They can't breathe. Cyanosis would be a very late sign, right? So if you see cyanosis, that's a pretty late sign. And the reason I put cough there for two reasons. One, there is a type of asthma called cough variant asthma, where instead of wheezing, they cough. But it's not a hacking bronchitis type of cough. It's a weak, ineffective cough where they're like, they can't cough with a lot of force. Now I have to drink something. They can't cough with a lot of force because they, you know, they don't have a lot of air to be able to move because they're so tight. The other time you'll see that type of cough is when you're using the albuterol on them and they start to open up, right? That's one of the signs we always look for to know that when you're using the albuterol that they're actually opening up, is they get that kind of weak, ineffective cough for, you know, a minute or two, and that tells you the albuterol is starting to open up. Okay? Some more serious signs and symptoms would be accessory muscle use. So your main muscles, if you're an adult, are your diaphragm, right, which is the separation between your abdominal cavity and your thoracic cavity, that bell-shaped muscle. I'm kind of, well, I can't get the thing to go where it needs to go, but over here, right, that bell-shaped muscle. Okay, and your intercostals, which are between your ribs, and you also have intercostals that go this way. Okay, those are your main muscles of breathing. In kids, it's really just their diaphragm up until probably 5, 6 years of age. So if you see their neck muscles, you know, their clavicles, and stuff like that, or they're using their stomach a lot to breathe, that's considered an accessory muscle in adults. If they can't speak in complete sentences, that's usually obviously somebody who's short of breath, okay? They start getting very, very, very antsy, and that's sometimes hard to tell, right? They may just be a nervous Nelly or hypochondriac, but you know, if they're really getting nervous, that's obviously a sign of hypoxia. That prolonged, really prolonged expiratory phase, it says that it takes twice as long, sometimes 3 times as long for that asthmatic to exhale than it does to inhale, because it's so hard for them to get the air out, which would tell you that if you're ventilating them, okay, you have to really, and if they're really, really tight, so if it's taking you, I don't know, 5 seconds to get their chest to rise, it's going to take you 15 seconds. You may need to press on their chest to get them to exhale. Okay, so it's really hard. And they do need to exhale, because if they don't exhale, right, you're not getting the CO2 out. And if you keep on trying to ventilate them, you may even cause a pneumothorax. So you do have to let them exhale. If you see them tripoding where they're supporting their weight on their arms, okay, that's obviously something that they, they don't know they're supposed to do. They just find it's more comfortable to be able to do that. And the reason it helps them to breathe is that it allows their diaphragm, when they press down and rest their weight on their arms, it allows their diaphragm to go down a couple centimeters more. They just get a little more air in. And then in little babies, you may see nasal flaring and stuff like that. You can see that in COPD or sometimes too. Okay, now, before they go into this status asthmaticus, this dying stage, one of the things that happens is what's called respiratory muscle fatigue. And they go into what's called the stage called respiratory failure. So usually we get people in respiratory distress, and sometimes we get people not breathing, and sometimes we don't recognize this in-between stage, which is called respiratory muscle fatigue. So picture this, the asthmatic is breathing 70, 60 times, 40 times a minute, right? Puffing and puffing. Now, if they start breathing real fast, one of the things that happens is that their tidal volume drops, right? The time between each breath starts to shorten, and so the time they have to take a breath starts to drop. So the amount of air they bring in starts to drop. And the other reason the amount of air they bring in starts to drop is because they're tight, right? They can't get a lot of air in. So right now we're breathing between 400 and 500 mLs of air. So, about a little water bottle, a medium water bottle amount of air at rest. Okay, and we can greatly expand that if we were running or exercising and stuff like that. Of that, say 500 mLs of air you breathe, 150 of it is stuck in what's called the dead air space from your nose to right above your alveoli. So that's not available for gas exchange, which leaves 350 mLs available to get down to your alveoli for gas exchange. So if you start to go into respiratory muscle fatigue and you can't breathe deeply and you're tight because you're having an asthma attack, and let's say you cut that tidal volume from 500 mLs to 350, okay? So 150 is still going to get stuck in the dead air space. And now they only have 200 available for gas exchange. So you can see what starts to happen is they get hypoxic, their CO2 level starts to rise, their mental status starts to decrease. They start doing what's called head bobbing, where they can't stay awake, and you find them kind of like this. So all of that's indicating they're going to die. If you don't get aggressive with them, they're going to die on you. So at this point, they can't use the albuterol, right? They probably can't use CPAP anymore. So really what has to happen is you probably have to lay them down and start ventilating them, okay? Now, if they let you lay them down and ventilate them, you know your diagnosis is right, because anybody who's having that level of trouble breathing is never going to let you lie flat. Let them lie flat, right? They don't want to lie flat. It increases their trouble breathing. So if you start ventilating them, then you know that your diagnosis is right. Now, you may get some oxygen into them, and they start waking up and pushing the bag valve away. That's great. Don't fight them. Sit them back up, tell them to breathe, and put them on CPAP. If you maybe had got them on CPAP before they got so bad, they might not have gone into this respiratory muscle fatigue. Right? So CPAP's a great device, but sometimes people just don't cooperate with it because it makes them, that big mask over their face makes them feel a little claustrophobic. So, it's especially if they've never used it before. A lot of times if they've used it before, they'll actually set it up and put it on themselves for you because they feel like you're going too slow. But that's respiratory muscle fatigue. Now, this is where that subcutaneous epinephrine, that intramuscular epinephrine, that Epi Pen or that check and inject would come into a role. If they're in this respiratory muscle fatigue and they're unconscious or barely breathing and not moving any air and they can't use the nebulizer and they're dying in front of you, this is where you would call medical control and say, is it okay if we go ahead, here he has a history of asthma, he was home for 4 hours trying to treat himself. The time we got here, he was already semi-conscious. Can we go ahead and give him the Epi Pen that we have, or this check and inject epinephrine? And if you want to say, we're going to give him 0.3 milligrams because he's over 66 pounds or whatever, that's the standard dose that you would give somebody, right? And and if they give you permission, you will go ahead and give it to them. Now, that should work to open them up, okay? But you have to realize that they're pretty far gone at this point, and their heart is very hypoxic. And epinephrine puts a huge load on the heart. So you could be dealing, helping their respiratory problem and hurting their heart at the same time. But really, they're crashing at this point. So whatever you do for them is better than just sitting there, watching them die. Because we know what the lungs look like. We know that, in asthma, it's these little yellow tubes, right, that are coming into the alveoli. So here's an opened up alveoli so you can see inside. It's not actually a bag. It's actually a bag with multiple bags inside of it, or they call it multiple rooms inside of it. So it's not just a big open structure. There's actually multiple little walls inside of it, so there's more area for gas exchange to take place, okay? And then wrapped around the alveoli, or alveolus, if you have one, okay, are a network of pulmonary capillaries. So they're showing red and blue because obviously capillaries bring in oxygen and take out carbon dioxide, right? So it's not that they're half capillaries, but half the capillaries are CO2 capillaries and half are O2 capillaries. They both can do, the same thing, right? And those are microscopic. You can't see them with a naked eye, thin-walled vessels. And these are the vessels where all perfusion takes place. So this is where sugar diffuses into cells. This is where oxygen diffuses into cells and stuff like that. So, you have many more miles of capillaries than anything else. And the whole reason why you have arteries is to bring blood to capillaries. And the whole reason why you have veins is to take blood away from capillaries. So really it's the capillaries that keep us alive. That's where perfusion takes place, and the nurturing or the feeding of the cells with nutrients and stuff like that, and the removal of the waste products. Okay, so nebulized albuterol. So this protocol now, the new one, says that if a patient's wheezing, use albuterol. I know some of you remember that they had to be a history of asthma, and they had to be between the ages of 1 and 65, previously diagnosed with asthma, blah, 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 blah. They took all that out. There's no more ages. There's no more asthma. There is, if the patient is wheezing, you can use albuterol regardless of the etiology of the wheezing. Okay? Your agency has to have permission to use albuterol, which I believe all of you have, and you have to have had training in the use of albuterol, which again, I believe all of you have. The albuterol that we administer is prepackaged, right? It's 2.5 milligrams and 3 mLs of normal saline, and we adjust the nebulizer typically to a flow rate of 6 liters per minute. You can go 4, but most people use 6 liters per minute. There's no real reason. I wouldn't go faster than 6, but most people, I haven't seen anybody really use 4. Sometimes in a hospital they do, but 6 liters is the typical. You don't have to stay at the house to finish the treatment. You can do it, wait till you get them to the ambulance, or continue it from the house into the ambulance, and so on and so on. Sometimes if you treat them in the house and make them better, they want to stay home, and they're really probably not at the point where they could stay home, and they're just going to call you back in a couple of hours. So it's better just to take them. So you're allowed to give a total of 3 doses of albuterol. Okay, the first one, you may start in the house, second and third en route. If you have a decent transport time, you shouldn't fear giving 3 doses of albuterol. If they don't feel 100% better after the first one, start the second one. And the same thing, if they don't feel 100% better after the second one, give them the third one. So you don't have to fear it. In the hospital, they get back-to-back albuterols, it could be 5, 6 of them over a couple hours till they're totally opened up and stuff like that. So don't fear giving it. It is going to make them feel a little jittery. You know that when you're using albuterol, after a couple of minutes, it doesn't mist as much. So take it out of their mouth, hold the medication chamber, sometimes people call the acorn, and slap it a couple times, and then give it back to them, and they'll get a couple more minutes of using it and stuff like that. So albuterol is a bronchodilator. It's what they call beta-2 specific, so it mainly works on the lungs, not so much on the heart, but it does cause, some tachycardia, some jittery and stuff like that. So those are all possible, but not as much as epinephrine does. So it does have some minimal side effects on the heart. And, they're fairly common. Most people will get a little tachycardic. They will get a little jittery. Some people say they hate the way it makes them feel. And I always say to them, well, what's the better feeling, the can't breathe feeling or the jitteriness? And then they say, okay. So again, 2.5 milligrams and 3 mLs of albuterol is prepackaged. Nebulizer at 6 liters per minute. You can give a total of 3 doses. Okay, so we're going to talk about how we do it. So everybody gets different nebulizers. It's by us, it's whatever the hospital buys, the cheapest and stuff like that. But it typically comes packaged with all of this. Some of them actually have some corrugated tubing. I'll show you. They can go on over here. But they always come apart for the most part, in pieces and stuff like that. So the first step would be to find the 2 parts to make the medication chamber and put them together. Right? So you can screw this onto this. I would wait before you put the medication down to put the tubing on and stuff like that. But usually once it's all together, I squirt the medication right down here. Some people put the medication in here now, but I don't know. I just think you're more likely to spill it. Okay. So I usually wait till it's together and I just squirt it down here, put the oxygen on. This piece here comes onto here. So it looks like a T. The mouthpiece typically only goes on one side. And if you have the corrugated tubing, it goes on the other side. The oxygen tubing on some of them, it's marked blue on the part that goes into the nebulizer, and the little nipple, which you could barely make out over here, would be blue. And that would fit on there, and then the other side is green. So green always goes to the oxygen. But if there's no markings, then it's universal to go on either side. Okay, this is how we carry albuterol. I don't know if this is how you carry it, but the one thing that's a little weird with this is that obviously this is a twist off top. If you put your fingers here and on the back of it, right, and twist this off, it's going to spray out. Not all of it, but some of it's going to spray out. So the better thing to do would be to put your finger here and here and be gentle. Twist this off very gently, and a little bit will come out, but you won't lose as much as if you have your finger here and on the back. The other problem with this one is that it's very hard to read it, the expiration date. The expiration date is imprinted on here, and you have to know which side it's imprinted on, so it's very, very hard to do it. I see sometimes people take a black magic marker and kind of color it in, and it's maybe a little easier to see stuff. Okay, this is it with the corrugated tubing on. Okay, this is a nebulizer mask. So you could make this out of a non-rebreather, but the only thing that's different than the mask on a non-rebreather is you see it has a huge hole here, and it also has another hole on the other side, where we have small, basically small holes drilled in it on a non-rebreather, and we have a gasket. So if you're going to use the non-rebreather, just pull the gaskets off and rip out bag, whole plastic piece with the bag out of here. You basically made the same thing, using it. And this would be a situation where the patient is not able to hold the nebulizer. Or maybe you want to use it as a blow-by, like in a kid. You don't want to strap it to their face, but you want to just have the parents hold it in front of their face and stuff like that. So that would be a way of doing it that way. Okay. So again, the Epi Pen, we said, is a last-ditch effort in a dying asthmatic. Okay, it's only a medical control option, which means you can't do it on standing order. Okay, and it's a patient who has to be pretty much out of it, dying in front of you, not moving any air, can't use albuterol because of their status, their mental status. They're not a candidate for a CPAP or anything like that. So it's for kind of last-ditch effort. Okay. We know that Epi works very quickly, works very well. The issue is that it increases what's called the myocardial oxygen demand, which is the amount of oxygen the heart needs at any one point. And when you're hypoxic, because you're having an asthma attack, you can't meet that demand, right? You give somebody Epi, it's like a car going from 20 miles an hour to 200 miles an hour, right? It's burning much more fuel and oxygen to go that fast. The same thing when we give somebody a shot of epinephrine, now their heart has to work much harder and it doesn't have the oxygen it needs. So it can lead to a mismatch, but they're going to die, right? You're only thinking of using this if you're thinking appropriately in an asthmatic that's about to die. So, pick your poison, I guess, at this point. Right? So we know that the cutoff between the adult dose and the pediatric dose is weight specific. It's 30 kilograms, which works out to 66 pounds. And if that's the case, the adult Epi Pen is 0.3 milligrams. Okay. And if they're less than that, you get the pediatric, because 0.15. So 0.3 is actually 0.30. So it's actually double the adult and double the pediatric dose. So the pediatric dose is half the adult dose. Okay. If you only have an adult Epi Pen, you have a dying kid that's under 30 kilos, by all means, give him the adult. Don't worry about it. Okay. And if you have an adult who has an asthma attack and you only have the pediatric, give them the pediatric, and hopefully they have two, so you can make the adult. But if they don't, give it to them. You can't hurt them. You may not help them as much, but you can't hurt them by giving them the pediatric dose. So, okay, so any questions on the respiratory, the asthma, or anything like that? If you have a question, unmute yourself. You did see the whole thing, right?
Mm-hmm.
Okay. If for some reason the PowerPoints don't come up, just tell me. Okay, how are we holding up? We can go a little longer?
Yes.
Okay, do you see the new one, shock and bleeding?
Yes.
Yes, it's up.
Okay, so we all know what bleeding is, right? We all know that blood has three components, or I should say more than three components, but has two main components: the fluid portion, which is the plasma, okay, and then the cells, the red blood cells, the white blood cells, and the platelets, right? And the red blood cells have a substance called hemoglobin, okay, and hemoglobin is the substance that carries the oxygen. So we need all of those to, have life, okay? And when we lose blood, we're gonna have a problem with having life. So losing blood is one form of shock, which is called hemorrhagic shock. We're going to talk about all the different causes of hypoperfusion, or the old way was shock, but now the new way is hypoperfusion and stuff like that. So we have different types of bleeding. When we're talking about hemorrhagic, we know arterial bleeding is spurting and bright red, right? We know venous. We also should know that people can die pretty much as quickly with venous bleeding as they can with arterial bleeding, right? So we should treat that just as significant. It's really the amount of blood, not the vessel that's bleeding. And capillary bleeding, for the most part, will not cause death, right? That's what most of us see when we cut ourselves, is capillary bleeding and stuff like that. Okay. Now, how do we control bleeding? So if it's internal bleeding, they need to get into surgery, right? There's not much that we can do for internal bleeding to try to control it. So we can control bleeding on the extremities. Where we can't control bleeding very well is what they call junctional trauma, right? Somebody shot in the axillary area, the armpit, or in the groin. Those we can't control very well unless you've gone out and purchased some of these fancy, junctional pressure devices and stuff that are out there. But, thankfully, we're, for what we do, it's pretty rare. In the military, it's a bigger issue, but what we do is it's pretty rare to have that kind of junctional trauma. But on an extremity, we can definitely control it. So direct pressure with hemostatic gauze, for the most part, will stop the vast majority of your bleeding. And we need to know a couple of things about hemostatic gauze, right? We need to know that it needs to come in contact with the bleeding vessel, which means that if you get there, somebody's packed a towel in the wound or something like that, what should you do? You need to, and it's still bleeding, right? If they pack the towel in the wound, the bleeding has stopped, and just wrap it up and take them to the hospital. You don't need to expose it. You don't need to do anything. If they've stopped the bleeding, just wrap it up with some gauze, to put some pressure on it and take them to the hospital. Don't worry about it's not sterile because the wound's not sterile. They're going to be on antibiotics and they're going to get tetanus shot automatically. So, if somebody else managed to control the bleeding, then that's great. I always see people like, oh, let me look at it. Well, the bleeding stopped. You don't really need to look at it. You just need to wrap it up and take them to the hospital. Okay, so hemostatic gauze. So you have a wound. Okay, they put something in it when you got there, and it's still gushing blood out. So what you need to do is open your hemostatic gauze, have it all ready, okay, and then remove the object that's not working, and where you see the blood coming from, you need to pack the hemostatic gauze in there. Now, we know there's different types of hemostatic gauze. There's ones that come in a bag. There's other ones that look like roller gauze that you kind of fan-folded paper, like from the printers from years ago. That is not designed, the fan-folded one is not designed to go in whole. You actually have to feed it in because there's more, there's more surface area if you feed it in, strand by strand, so to speak. And that's how it works better. And I'm not saying it's easy. I mean, people got blood gushing all over the place and you're trying to feed all of that in there. It does become you kind of feel like you look like a jerk, feeding it all in there. So then once you get it all in there, you're probably going to have to use some non-hemostatic gauze or trauma dressing to fill up the wound, and then you're going to put direct pressure on it. But the hemostatic gauze only works if it comes in contact directly with the bleeding vessel. Okay, so there's a lot of different types. I don't think I have the fan-folded one in there, but there's a lot of different types of hemostatic gauze, a lot of different sizes. And QuikClot is not the only manufacturer of hemostatic gauze, but they probably have the largest market share. Okay, so again, we go to it if you can't control it by any other means. Pretty much, if you pull up and there's severe bleeding, I would go right to it. I wouldn't even waste the time to try anything else, to be honest with you, okay? So anything that's non-effective, you're going to pull out of the wound, but just open up your hemostatic gauze first, okay? This way, you're ready to go because these wrappers can be a little difficult sometimes to open up, especially if you're nervous and it's dark and stuff like that, and you can't find where the little tear in it is and stuff like that. Okay, so again, you're going to over the hemostatic dressing, you're going to put I don't know what keeps on going that way, but you're going to put a standard dressing. Okay, so you have the hemostatic in contact with the bleeding vessel, the regular dressing, which could be a multi-trauma dressing depending on the size of the wound, and then you're going to hold pressure. So the manufacturer of QuikClot says it could take upwards of 2 minutes to start to stop the bleeding and stuff. And remember, when blood's gushing out, 2 minutes seems like 2 hours. So a lot of people don't wait the full 2 minutes. And, I'm not saying it's wrong, but they go to a tourniquet a lot of times very quickly where, the hemostatic gauze may work if you give it enough time, but people may be screaming at you, do something, blood may be squirting your eyes, and, you just decide to go to the tourniquet. And it's not wrong in that case, okay? And then you're going to keep a pressure dressing in place over it, and you're going to monitor the site, okay, for bleeding. And then obviously let the hospital know. Now, all these new hemostatic agents are radio-opaque, which means they'll come up on an X-ray and stuff like that. But just let them know what you used, how much you used, because when they start cleaning out the wound, they need to pull everything out, or there's going to be an infection, in a couple of days. So they need to know if you used that much stuff, that when they start removing everything out, they should be able to account for it and stuff like that. Okay, yeah, and again, if it's I've never seen anybody consider hemostatic gauze on a eye wound, but you wouldn't put it on an eye wound. Okay, so tourniquets, doesn't matter whether it's a field improvised tourniquet that you make with a cravat or a piece of clothing, or a commercial tourniquet or anything like that. But a tourniquet is basically something that goes circumferentially around an extremity and can be tightened so that it shuts the flow of blood off to the site of the bleeding. Tourniquets are painful, and patients will, if they're conscious, will complain of pain from them and stuff like that. I had somebody who bled to death, I think it was 2 summers ago, that those guys that were riding a lawnmower on 17 in Sloatsburg and got hit by the car. The guy loosened his own tourniquet. He had 3 tourniquets on, and while everybody was working on him, he loosened one of the tourniquets and wound up losing a significant amount of blood and ultimately died before we got that tourniquet tightened back on and stuff like that. So it is painful, right? I mean, it's designed, it's designed to get real tight, and that's painful. Okay, so tourniquets are a life-saving device. They should not be, you should not be afraid to use a tourniquet, and you should make that decision fairly quickly. If you can't stop the bleeding within a minute or so, you should go to a tourniquet, okay? So here I wrote a final resort, but that was years ago. But again, use it quickly. Don't let the patient bleed to death and stuff like that. Okay. The whole TK thing, writing it on their head, that's more if you had a mass casualty situation or you were in a combat situation where you were not going to be accompanying the patient to the hospital. But if you're accompanying the patient to the hospital, you're going to tell the hospital that, there's tourniquets on and stuff like that. So you don't need to mark them up and stuff. If it's going to be a mass casualty situation and you're not going to be with the patient, then it would be a good idea to mark them up and stuff like that. Okay. Now I wrote, do not loosen or remove until definitive care is available. Question mark, question mark, question mark. So until we had the new protocol update, we were told never to remove a tourniquet, that it was going to release toxins into the blood and kill the person, and da 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 da. So that military dispelled all that. And basically the rule is that if you have a tourniquet on someone and the bleeding is controlled and they're not bleeding anymore, you could try to loosen it and see what happens. Now, it may be something like, I don't know, you're in Pine Island and somebody, God forbid, gets their arm stuck in a piece of farm machinery, and you got the bleeding under control with the tourniquet, but you got a hour, half hour, 45-minute ride somewhere. That may be a situation. If you're 5 minutes from the hospital, 10 minutes from the hospital, you're not going to have bleeding control, so you're never going to think to loosen it. It's more for people that have long transports, right? I'm talking, I would say it'd have to be close over 30 minutes to even consider it and stuff like that. And it's just that by reestablishing blood flow, you're less likely to have long-term damage to that limb. Now, even without removing the tourniquet, they studied the use of tourniquets up to about the 3-hour mark. And tourniquets that are typically removed within 3 hours do not result in the loss of a limb, for the most part. If the limb is lost, it's because of the trauma that caused you to put the tourniquet on. In other words, the pipe bomb goes off and blows, the extremity off. The tourniquet is not the cause of that person losing that extremity. The tourniquet is saving their lives. Yes, they're going to have an amputation, but the tourniquet is saving their lives. The other thing is, if, let's say the bleeding's down here, the tourniquet should really go, if you could, below the elbow in that situation.
Sorry, I'm having trouble hearing.
Should really go below the elbow if you could, right? So it has to go proximal. It has to go between the wound and the heart. That's always proximal, okay? But it should, if you could spare the joint, right? You don't want to be on the joint, but if you could spare the joint, that's always better, because if they do have to have an amputation, having their natural joint would be better range of motion and use for them than would be to have a prosthetic joint. So if you could spare the joint, by all means. Now, if you did the protocol update, you remember they talked about going what's called high and tight with tourniquets. That's because the guy who did it, again, I don't know. I don't want to talk bad about people, but high and tight is a military thing, which is, or let's say you're doing SWAT team medicine and stuff like that, tactical medicine, and you're in a shooting situation, right? There's an officer down, or your comrade is down, rounds are flying, you're laying on your belly, you can't lift your head up because it's going to get blown off, and this guy's got blood gushing out of his arm. You're not going to look and see where the bleeding is occurring from. You're just going to take that tourniquet and put it up real high and shut off blood flow to his entire arm, because that's all you can do for him. And that's what high and tight is. And so if you ever got forbid in that situation, that's what you would do. Okay? But the rest of the time, for most of us, it's not a combat situation where we have to worry about being shot or anything like that. So we would go closer to the wound that's bleeding in that situation and stuff. Something else I was going to say with high and tight that I can't remember right this second. Okay, so let's go on to some specific injuries and stuff like that. So epistaxis can be just because you have high blood pressure and you're bleeding. It can be because you picked your nose and stuff. We're talking about serious nosebleeds. I mean, I think you've all seen serious nosebleeds and stuff like that. Now, when somebody has a basilar skull fracture, they can have blood and cerebrospinal fluid leaking from their nose. It's usually not a significant amount, but that would be telling us more that they do have that basilar skull fracture. But sometimes when people have hypertensive crisis, they actually burst blood vessels in their nose, and it kind of acts as a vent to relieve some of that pressure. But the problem is they can lose a significant amount of blood. I mean, I've seen people fill up the spaghetti pots, with blood and stuff like that, where you got 2-3 inches of blood in there, and they're going to get woozy and they're going to get lightheaded and stuff like that from that situation. Okay? It could be because they have different type of clotting disorders, okay? And it could be just because they're sticking something up their nose, right? So it could be a significant amount of bleeding. We can only control bleeding that's from the external nose, which is the part that we see. But remember, your nasal passageways are all the way back here on both sides. So if they have a posterior nosebleed, that requires packing. There's nothing that you could do. All the pinching that you do and everything else you do for them is not going to control the posterior nosebleed. That's just going to be transport, and they're going to have to pack that wound. They have something called well, it's different ones, but the name I like the best is called the Rhino Rocket. So it looks like a long tampon, and there's a plunger on the end of it, and there's basically a super compressed gauze pad with a rope on it, a thread on it, and you stick this thing in their nose, you press the plunger, and it shoots this gauze pad into their nose, and then it expands. So it goes into the back, right back up into here, and you will see their eyes bulge when that thing starts to, expand inside their head. But it does control the bleeding pretty well. If any of you do any wilderness medicine or like any, you're like a real backcountry kind of guy, if you ever had that situation, I would assume you're going to be carrying like some epinephrine just in case somebody, gets stung by a bee in that situation. Like everybody should have a little, their first aid equipment or their medical equipment. So if you have Epi and somebody has a bad nosebleed, if you spray the Epi, it doesn't work so much with the auto injectors because you can't really spray it, but if you have to check and inject, spray a little Epi on a gauze pad and pack it up their nose. Epi is a vasoconstrictor. So they will get tachycardic, but you clamp down on their bleeding pretty much immediately if you can get the Epi up to where the bleeding is occurring. Okay, so again, what do we tell people with anterior nosebleeds where we can actually do something? So they should sit up, lean forward. Okay, they should pinch their nostrils together. Sometimes a cold pack will work and stuff like that. And again, it is uncomfortable, but the more they gag, the more they retch and stuff, the more they're breaking down the clots and stuff like that. Okay. So, there is epistaxis, there is nose bleeding that can result in serious, life-threatening bleeding. And if that's the case and they start getting woozy and stuff, you have to lie them down, I wouldn't fully lie them down, maybe, semi-recumbent, because you don't want to have an aspiration issue and stuff like that. But, the more blood you can get to the brain, the better it would be. Okay, so internal bleeding. So we could have from trauma, we could have it from bleeding from an ulcer, could be clotting problems, could be an aneurysm, right? There's a million different reasons, could be bone fractures and stuff like that. So there's not much we could do in those situations. And it's really just get them to the hospital because they probably need surgery or they probably need to have blood transfused into them if not a severe bleeding, stuff like that. So staying on the scene is inappropriate with them and stuff like that. Okay, so there's different signs that you can see, So great Turner sign where they get a bruise is over there. But again, for a bruise to develop is going to take hours. So hopefully they weren't sitting home, with that. Okay. They get Cullen sign. Sometimes an early appendicitis has periumbilical, the umbilicus is your belly button, has periumbilical pain, and you can get the Cullen sign with it if the bleeding is occurring there and stuff like that. But if you saw a bruise, you know something's going on. But the problem is at the time the bruise develops, it's hours into it and stuff. So, okay. They can be leaking blood from their from their rectum. They can be vomiting up blood. Free blood in the abdomen. It acts as ipecac, makes them vomit and stuff like that. So it's all different things that you can see and stuff like that. So pancreatitis again. Not that we see many ectopic pregnancies anymore, okay, but it can happen, especially if you live in a place where women don't tend to have access to a lot of prenatal care. But if you had a ruptured ectopic pregnancy, that's you can see it. And a ruptured aortic aneurysm, they're going to be dead before they ever develop a bruise or anything like that. And trauma, splenic injuries, spleen injuries are very common. But again, if they have bruise, it's hours and hours later. So for us again, it's probably the bruising is not going to be the most obvious sign. It's just going to be more of your signs and symptoms and stuff like that you can see. They can be vomiting up the bright red blood, right, which tells you it's not been in their belly for a long period of time. If they vomit up coffee ground looking material, that means it's partially digested blood. It was a slower bleed. It's been in their stomach for a while. And if they have blood coming out their rectum, it's going to look like a black tarry type of stool. And that's what blood looks like when it's mixed with it and stuff like that. Their abdomen is going to be tender. Okay, usually it's hard, it's distended and stuff. Okay, so let's get into the actual shock part of it. Okay, so all hypoperfusion means is that there's low perfusion. Perfusion means that the cells are getting what they need to stay alive. So the cells need, at the very basic level, oxygen and sugar, and they need to remove the waste products, which carbon dioxide and other waste products from the cell, right? And if they're doing that, then what's happening is we have what's called aerobic metabolism. Aerobic metabolism is making energy. Metabolism is making energy. Aerobic is making it with plenty of oxygen. Okay? And when you have aerobic metabolism, you make a lot of what's called ATP, adenosine triphosphate, which is our energy molecule. And the waste products of making that energy are very easily removed. The waste products are water and carbon dioxide. So we exhale the carbon dioxide and we reuse most of the water, but what we don't need to reuse, we excrete, okay? So that's ideal, that's what we're all doing now, and that's the way we should do it. When you don't have enough oxygen coming in, or you don't have enough oxygen making it to the cells because you have some type of hyperperfusion problem, and we'll get into the specific problems, then you have what's called anaerobic metabolism, and you don't have enough oxygen, you don't have enough sugar, whatever the problem is. You still make energy, but you don't make enough of it, and the waste product is something called lactic acid, which is very hard to get rid of. So that's the issue with hyperperfusion. It's just a, it's just a problem with the cells getting what they need to make energy. Remember, all your cells, your millions and billions of cells, every one of them is a little energy producing substance. So if you don't have cells producing energy, the body doesn't work and you die. So again, we have millions of cells. You can't see a cell unless you have a microscope and stuff like that. And again, cells need to make energy, and they do that by burning oxygen with sugar and stuff like that. So if you don't have enough oxygen or sugar, you don't make enough energy. If you don't have enough energy, you don't have life. And the cardiovascular system's role in all of this is it transports the oxygen and the fuel to the cells, and it removes the waste products from the cells. So it's the transport mechanism to get that energy, and we get that energy, that oxygen by breathing, okay? And we get rid of the carbon dioxide by breathing, and the fuel, the sugar, and all the other nutrients by eating, right? So the cardiovascular system has to be working well enough, okay, to get blood to the capillaries so that perfusion, which is the leaking of those substances from the capillaries into the cells, works. So you need good blood flow to have good perfusion, okay? So if you have adequate flow, you usually have adequate perfusion. We're going to talk about some situations where you don't. When you have inadequate flow, then you have inadequate perfusion, which we call hyperperfusion, and obviously hyperperfusion and shock are the same thing, okay? So what do we need to maintain perfusion? So you have to have a pump that works at your heart, okay? So how can we have shock caused by a pump problem? So that's called cardiogenic shock, right? And in cardiogenic shock, it can be rate dependent, which means that the heart is pumping too fast or too slow. Not much we could do on a BLS level when we have rate dependent shocks, pumping too slow or too fast. That's going to require, ALS or a hospital or something like that to give medicines or electricity to kind of slow it down. Or we could have problems with the valves. Again, nobody's going to deal with that except a heart surgeon. Or we could have actually people have damage to their heart, right? So if you damage the muscle of your heart, especially the left ventricle, it will not pump effectively. And if you can't pump effectively, you're not going to have a good flow. You're not going to have good perfusion. So how do people have pump problems? Well, we've learned that COVID can do that. We've learned that people who have heart attacks and don't get treated right away can have muscle damage. We learned that people who have infections that are not even COVID, right? They're just not lucky and they get a bacterial infection and goes to their heart. They can have those types of things. So whatever the cause is, they can have damage to their pump where it cannot squeeze and pump effectively. And in the short term, if they can get to a hospital that has the right equipment, they can go on an ECMO machine, which is called an external corporal membrane oxygenation, where they cannulate the femoral artery and the femoral vein and run the blood through a machine that oxygenates and cleans it. In the long term, they can get LVADs put into them. And then if they start to get better in the real long term, they can get a heart transplant. So that's what kind of happens to people in cardiogenic shock. The mortality rate of cardiogenic shock is in the 90s. But every year that goes by, there's better options for these people because of all these new treatments. Another way you could have a problem with perfusion is the problem with the tubes, the blood vessels. So the big problem for shock from the tube standpoint is that there's massive vasodilation. And that's your sepsis. It's all your distributive shocks, your sepsis, your anaphylaxis, and your neurogenic. Okay. Or that the pipes and tubings get obstructed, blocked, and that's like your embolisms, your pulmonary embolisms, your tension pneumothoraxes, your cardiac tamponade, where the heart sac is filling with blood and pressing on the heart and not letting it pump. So those are all your obstructive shocks, where the problem is that the heart can't pump through a vessel because it's blocked. And then you have the fluid ones, which is what we really think about, right? So if we lose blood, it's hemorrhagic. And if we lose fluid other than blood, it's called hypovolemic shock, like if somebody has vomiting and diarrhea and stuff like that. So how can perfusion fail? The pump doesn't work, the tubing dilates, or you lose blood or lose fluids from the body, right? So those are all the different things that we know already, okay? Now, shock is not the same thing as low blood pressure. I mean, some of you may just, if you're a 110-pound female who exercises, you may have a blood pressure that we can't auscultate very easily. It's because why? You're low weight and you're in good shape. Your heart doesn't have to pump very hard. Okay, and you may not need a great blood pressure. So just because of the fact that somebody has a low blood pressure doesn't mean that they're in shock. I had an EMT student that I used to use for vital signs because he exercised religiously every day, and his heart rate was in the 40s, and his blood pressure you couldn't hear. You really couldn't hear it with a regular, stethoscope. So I would take students for testing purposes and send them to him, and every student would come back and say his pulse was 72 or 80, and his blood pressure is 120 over 70. When I sure as hell knew that it wasn't that, because we knew what his true vital signs were and stuff. But that happens. You can definitely have it. We had a young female patient that fainted. She's probably 17, 18 years old. She fainted. They couldn't get a blood pressure on her. It was back in the day when there were mask trousers. They put mask trousers on her. They put IVs in her and everything like that. And all it was she had a fight with her boyfriend. So she wound up in mask trousers, IVs and everything because they couldn't get a blood pressure on her. She just was a light, thin little woman and didn't have much of a blood pressure to start with. Okay, so shock goes through different stages. So the earlier compensated stage means that the body is doing something to keep the blood pressure up. And what are they doing? It's increasing the heart rate, it's increasing the breathing, it's constricting blood vessels, it's preserving fluids. So there's a lot of different things that go on in the body. And when that, early on, that will help keep the blood pressure normal. When that starts to fail, they go into the decompensated stage, which means that the blood pressure starts to drop. So our goal would be to try to keep them in the compensated stage, or at least get them to the hospital in the compensated stage. An irreversible shock is when the body starts to, because there's such poor blood flow, the body starts to clot up the blood vessels, the small capillaries and stuff like that. That leads to organ failure. Typically, the renal system, the kidneys shut down first, and it's pretty much there, like it says, irreversible. Once your kidneys shut down, you go into renal failure, and it's kind of the beginning of the end. Okay. So, and we said in compensated shock, those mechanisms kick in to maintain blood pressure. We talked about some different things that happen. Your body has the ability for its own hemostasis, right? We talked about hemostatic gauze. So your body has the ability for its own hemostasis. We have platelets, we have fibrin, we have substances that do a pretty good job, okay, in controlling bleeding, or at least slowing down bleeding. The problem when we have arterial bleeding is that, they can't stick long enough to do their job before they're pushed out of the way. So by putting a tourniquet on, sometimes we slow that blood flow, right? Or we stop that blood flow and allow the platelets to actually make a clot and the fibrin to make a clot and stuff. Okay, so there's a lot of different things. We have different hormones that are secreted, like antidiuretic hormone that helps to control fluid loss in the body when you go into shock. And then when you move into the later stage, or the later decompensated stage, your blood pressure falls because those compensatory mechanisms cannot keep up with the blood loss or the shock. And then perfusion drops, okay, and everything starts to go south in those situations. And then as blood flow gets very minimal, everything becomes stagnant, okay, and that's when you start getting the renal failure, okay, and then they go into the irreversible shock and stuff. So sometimes you've probably seen patients, like you've gone to a nursing home, the patient's been septic for 5 days, right, and just been laying there, and they're cold, they're icy, and there's really no signs of life. They're in irreversible shock, and the staff may even, or you may ask the staff, are they still putting out urine? And the staff says no. Well, they're in irreversible shock at that point. So there's nothing really much to do at that point to save them, unfortunately. And that's what happens sometimes. Like that's what was the whole problem with COVID, when families weren't able to get into the nursing homes. There was nobody to push the care of their patients and stuff. Not that in a lot of those situations anything could have been done, but in a non-COVID environment, sometimes having a pushy family gets better care. Right? Okay, so let's go through some of the types of shock and what we do for them. So we have cardiogenic shock, we have distributive shock, we have obstructive shock, and we have hypovolemic shock. So we'll talk about all of those. So in cardiogenic shock, we said there's a problem with the pump, which is the main way, or it could be rate-dependent shock, which is not much that we can do. So that's like somebody going into an SVT or VTAC or a sinus bradycardia or a heart block. Those really require, on a BLS level, there's not much that we can do. So again, the heart's output depends on how often it beats, okay? And too slow or too fast is a problem, right? How hard it beats, that's called the contractility, how hard it squeezes, right? So it squeezes with more force, it pumps more blood. Okay, so you could have rate dependent, or you could have pump dependent or squeezing dependent problems. Okay? So again, probably the main cause of why people go into cardiogenic shock would be they have a heart attack that's not treated, or they delayed treatment, or they just couldn't treat it, and they get left ventricular damage. Okay, bradycardias, tachycardias, there could be valvular problems. Most valvular problems are either old age or infection. Okay. Ruptures of the myocardium are fatal most of the times. So what happens is most people have a rupture of the myocardium have had a previous heart attack. Right? So they've had a heart attack. Typically happens within the first year of having a heart attack. So when you have a heart attack, you develop scarred area, right? Because part of that heart has died, okay? And it develops scar tissue. So now the rest of the heart is going like this, is squeezing and moving, but the scar tissue stays fixed, right? It's not able to contract. It's hard, like when you have a scar on your hand, it's hard tissue. Sometimes that hard tissue just blows a hole, just rips free. And the person, has what's called a myocardial rupture. So they're going to be dead within a matter of a minute, and there's not much really to do for those patients. That's found on autopsy type of thing. But if they have a little leak, then there's possibly, I don't know how they fix it, but there's, I guess, possibly something you could do. So I asked the question, I said, how would a high heart rate, so you have a tachycardia, you have a person in supraventricular tachycardia, SVT, how can that cause them to get shocky? So you have what's called decreased ventricular filling times. Here's the heart, right? So right now our heart is going 6 to 8 times a minute, and the ventricles have plenty of time. Hold on one second, somebody's asking me. Oops, disappeared.
We lost it.
Oh, hold on for a second. Your sound is degenerating quite frequently. You hear me now?
Yeah, but we lost the picture.
Lost the picture. Is it there now?
Nope.
Nope. Hold on. Let's see. There now?
Yes.
Okay. Sorry about the volume. Okay, so I'll talk a little louder. I was starting to rest back in my chair, and I guess I'm too far away from it. Okay, so I asked, how would a high heart rate cause a decreased cardiac output? So when your heart is beating 60 to 80 times, 60 to 100 times a minute, really pretty much for most of us, under 150 times a minute, the time between each contraction is adequate for the ventricles to completely refill with blood, right? So you have plenty of time for the ventricles to refill with blood. Therefore, there's plenty of blood for the ventricles to pump out, okay? When your heart rate starts to exceed 150 per minute, you have what's called decreased ventricular filling time. So now it's going like this, and the time in between each contraction is less, so that the ventricles do not fill with enough blood. So therefore, there's not enough blood to be pushed out, and your pressure drops. And that's the problem with SVTs and VTACs and stuff like that. Now, we've all exercised to the point where we get our heart rate up, probably north of 150, but that is a situation that's occurring because of exercise, and there's other things that are going on in your body, and you typically keep your blood pressure up in those situations. We're talking about a situation here where it's an intrinsic problem with the heart that's causing it to beat so fast, and there you will eventually start to drop your cardiac output and stuff like that. Okay. So I put the hint there, ventricular filling time. So you have decreased ventricular filling time. Okay, so again, signs and symptoms of cardiogenic shock are what looks like a dead body, right? It's a cold, frozen, lack of perfusion type of body. If your heart's not pumping blood, your entire body is not being perfused. So typically they have an altered mental status up to unconsciousness. If your left ventricle can't pump into the aorta, blood does back up backwards into your lungs. So you go into pulmonary edema, you have rips, you may have wheezing. Your skin is cool, pale, and diaphoretic. It may be mottled, okay, where it looks like it's black and bluish discolorization. That's the sign of total lack of perfusion in the body and stuff like that, okay? So again, respiratory rate increased in labor to start with, but then they get real shallow. Pulse, again, depends whether it's rate dependent, where it could be slow or fast. If it's the muscle damage, typically starts as fast and then gets slow just because the heart is damaged. Blood pressure starts to drop. So what can we do for them? There's nothing really other than get them to the right hospital fast. So a patient in cardiogenic shock has to go to a Hackensack or a Westchester or something like that. The local hospitals will have very little to do for those patients. So all we can do is keep them oxygenated as best we can and stuff like that, and ventilate them. There's not much we can do. Okay. The next type of shock is called distributive shock. So distributive shock is also referred to as the confusing or fooling shock. Distributive shock is not caused by any problem with the pump. It's not caused with any problem with the fluid. It is caused with the problem with the tubes, the blood vessels. And in distributive shock, the blood vessels suddenly vasodilate. So picture that right now my blood pressure is 120/80. I'm very proud to say I've gotten my blood pressure down to like under 110 now with diet and exercise and watching my salt. It's stressing my wife because my blood pressure and cholesterol is better than hers. So that's a lot of incentive in itself to keep exercising. But anyway, your blood pressure is 120/80 when your vessels have the right level of constriction on them. But now, because you're septic, say, they suddenly open up and dilate. So you don't gain any blood, right? So if your blood vessels dilate, your pressure has to drop. So in this shock, it's a shock caused by the fact that the blood pools and doesn't distribute because the blood vessels open up. So you have a redistribution of blood away from your vital organs out to your skin. Okay, and so the vital organs are deprived of it. Now we have a couple different types. We have anaphylaxis, and I know most of us think of anaphylaxis as a breathing problem, which it is. But obviously, it's called anaphylactic shock for a reason. So typically in anaphylaxis, you start with the skin symptoms, the hives. Okay, the vasodilation gives you red skin and hives and everything like that. Then you have the respiratory issues, right, where you can have upper airway tightening of the larynx that causes stridor, lower airway tightening that causes wheezing. Okay. But then, untreated, it moves on to the vasodilation and causes the shock component. And the problem, if you get them in the shock component, is the epi that you give them as an injection in their arm is not going to be absorbed and work, and they're going to die, right? So if you give epi to somebody who's just having trouble breathing, they're going to get better. But if you have epi to somebody who's in shock and they're deep into shock, it may not work. Okay, neurogenic shock is the rarest form of all the shocks. Okay, and it is a type of distributive shock. It's caused when somebody either has a transection of their spinal cord, okay, or they have pressure, a contused cord, swelling, putting pressure on their cord, or shifted vertebrae. You know that the spinal cord runs through your vertebrae, so you have a vertebral injury, okay, where the vertebrae are not broken, but they actually shift and put pressure on the cord. So any of those situations, what happens is that your sympathetic nerve pathways that make your blood vessels constrict, that's your fight or flight ones, you give you tachycardia and blood vessel constriction when you're scared, all those things, those run through your sympathetic nerve tract, so that runs through your spinal cord. So if they don't work, your other nervous system called your parasympathetic, that goes from your brain directly to different parts of your body, not through your spinal cord, dominates. And you know that your parasympathetic slows things down, right? It's the one that when somebody vasovagals, it gets bad news or sees blood, their blood vessels dilate and their heart rate slows down. They don't get enough blood to their brain, they faint, right? So what happens in neurogenic, okay, is that they get a spinal cord injury or something like that, and they suddenly can no longer keep their blood pressure going because their blood vessels dilate and their heart rate slows down. Now, and let me just do sepsis, and I'll explain to you why we call it the distributive one. So sepsis is what? We know that sepsis is that a person has gotten an infection that has made it into the bloodstream, and the toxins that are released by the infection in the bloodstream cause that vasodilation to occur. So again, how people die of sepsis is, again, lack of perfusion of the organs because they have the vasodilation and they're not circulating the blood properly, okay? Now, vasovagal is technically a distributive shock when they faint because they see blood or they get bad news or I don't know, something causes them to activate their parasympathetic nervous system, but it's not really life-threatening, right? They faint, and unless they hurt themselves falling down, typically once they get supine, it's easier for their blood to make it to their brain and they start to wake up. And if we get there and we elevate their legs a little bit and we put them on some oxygen, they're usually fine. And we just have to examine them for any trauma from the fall and stuff like that. So those are the types of shock. And so in neurogenic, we said it's a spinal cord nerve pathway interrupted. So the parasympathetic nervous system dominates, okay? And that causes the loss of peripheral resistance in your blood vessels, which is what causes the vasodilation, right? If you don't have any resistance in your blood vessels, they dilate. Okay, there can also be ventilatory difficulties if you have a spinal cord injury because the nerves that send signals to your diaphragm and your intercostals don't work, right, because they're interrupted. So I asked the question, what happens to the pressure in a closed system if you increase its size? Well, in other words, your blood vessels are a closed system, and there's a certain blood pressure there. Now, all of a sudden, because you have a neurogenic shock or any of the distributive shocks, your blood vessels dilate, your pressure has to drop, right, because you didn't gain any more fluid in that process. So that's why the people go in. So why do we call this the confusing shock? In the vast majority of shocks, the patient's skin gets cool, pale, and diaphoretic, right? It gets cool, pale, and sweaty because there's not good blood flow to the skin. In distributive shock, we said it's a redistribution of the blood from the core vital organs out to the skin. So initially in distributive shock, whether it be anaphylaxis, whether it be neurogenic, or whether it be sepsis, you see warm, perfused skin with bounding pulses. A lot of times we don't see that because most of the distributive shock we see is sepsis. Most of it is nursing home patients, and most of it is taken 2 or 3 days before they called us, so they're no longer in that compensated stage. But if for some reason, you got there, you actually see somebody with warm skin. So probably the one way we do see it is in anaphylaxis, right? When you see that flushed skin and they tell you their skin feels warm and you see hives, that's all that vasodilation that's causing them to go into shock. They're just not in shock yet. Okay, so in neurogenic shock, it's the most confusing because when parasympathetic dominates, the heart rate slows down. So we think of tachycardia in shock all the time. So in the neurogenic one, you're going to have warm skin, bounding radial pulses, dry skin, right, flush skin, and a slow pulse. And you're going to say, well, that cannot be shock because that's opposite of what I've been trained to think of as in shock, but it is parasympathetic shock. Now, what's one thing, somebody unmute themselves and impress me. What's one thing that you see in neurogenic shock and only in neurogenic shock, and you'll see in no other shocks? And I'll give you a hint, and you only see it in a guy, in a man.
They get hard.
They get an erection. It's called a priapism, right? Because to get an erection, a man has to have vasodilation. And we just said that in neurogenic shock, there is vasodilation. So if you have somebody who fell off a ladder and is unconscious and laying there and he has an erection, he has a spinal cord injury, okay? Or he could be conscious. He may not know he has an erection because he can't feel anything there anymore. But if you happen to notice, right, that he has an erection, you know that it is definitive that he has a spinal cord injury. Okay? So unless he's just a horny little devil, but no, most of the time they have a spinal cord injury. So signs and symptoms, we said normal to slow pulse, okay, low blood pressure, respiratory distress because of the paralysis of the respiratory muscles, okay. Skin is going to be warm initially, but again, most of the times we may not get there right away. Or maybe this is a diving accident, right? Somebody dove in and hit their skull or hit their head on a rock. So now they're coming out of the water and they may be cold just from the water. So sometimes, right away they could not have that warm skin. Okay, again, they may have sensory and motor deficits from the paralysis, priapism, okay? It's actually spelled like the one on the right most of the times, okay? Even though I pronounce it with prism, it's prism. Okay, so what do we need to do? We need to make sure they have an airway. They may not be able to swallow. They may need to be suctioned. They may not be able to breathe, okay? So we have to ventilate them. They may be cold, so we may need to dry them and warm them, okay? On an ALS level, they're going to give them fluids to fill up that greatly increased vascular space. They may think of vasopressors, although I would say since we're so close to hospitals, they probably should just drive past the hospital. Okay. Psychogenic shock is another form of distributive shock. Again, simple fainting, vasovagal, could be blood, could be scared, could be whatever, pain, and they just all of a sudden activate their vagus nerve, their 10th cranial nerve, and they, boom, 1, 2, 3, their heart rate slows down, their blood vessels dilate. If they're sitting up, they don't perfuse their brain, and they lose consciousness. A lot of times they will precede it. The patients will say, not the patients, the bystanders will say they had a little seizure activity, and that is just the brain not getting enough blood, and it has this, the patient has a seizure. It doesn't mean they have epilepsy or anything like that. So if they did not hurt themselves, okay, on the way down, it's what's called self-limiting, which means that once they get supine, they start to perfuse their brain again, they slowly start to wake up and stuff like that, okay? So the two problems that produce hyperperfusion are the vasodilation and the bradycardia. So if you're slowing your heart rate and dilating your blood vessels, your pressure has to drop, and therefore, if you're sitting or standing, you're not going to get enough blood to your brain. I mean, sometimes you could take a warm bath, right? And you suddenly get up and you feel like you're going to faint. Okay, so there it's just the warm bath has caused vasodilation, and you're pooling blood. Okay, and that's sometimes people face plant getting out of a hot tub and stuff like that. Okay, so again, signs and symptoms can be anything, right, up to an automatic step to and including consciousness. They usually feel weak and dizzy. Okay, although they improve, okay, the headache is secondary to the fact they're not getting enough blood to their brains. They usually have a transient bradycardia, a transient hypertension. Respirations are usually fine, although if you get them when they're really not perfusing well, let's say you witness it, they may actually have snoring respirations. It may even look like they're seizing a little bit and have a little tongue biting. That is just the brain not being perfused. Okay. And again, the skin initially will be cool and pale. Usually it's not sweaty, but will rapidly improve. So what do we do for them? I would keep them supine, put them on some oxygen. If they have a big belly, loosen their belt. Okay. Elevate their legs and just let them sit there until they start feeling better. Sometimes a cool compress might make them feel a little better. Okay. And then once they start feeling a little better, I would get a good solid set of vital signs supine. Okay. And then I would sit them up with somebody supporting them, see what happens to the vital signs. If their heart rate doesn't drop, okay, doesn't increase too much, if their blood pressure doesn't drop, stays the same, I would leave them in a sitting position, see how they feel, give them a good couple of minutes, see how they feel. And if they're feeling okay, I would bring a chair alongside them and a stretcher alongside them. And then with people on either side of them, get them up into a sitting position on the chair, on the stretcher, reassess them. If they're still going, so we're talking now, we're into, the 5-10 minute mark. If they're still feeling okay, then I'd have them stand with people supporting them, recheck them again, give them another couple of minutes standing up and see how they do. Okay, and if they're all okay, I wouldn't say to them they could stay home, because I never say that to people, but I would say, let's take you to the hospital now. They'll probably say, I don't want to go. You'll probably say, I recommend you go. And then you fill out an RMA and you document that you recommended the patient to go to the hospital and they refused. Okay. Always check them that they didn't break anything on the way down. Okay. If they're on blood thinners and they hit their head, they have to go to the hospital. Okay. And, that's really it. That's basically, everybody's gone on these calls and stuff like that. Oh, I put down nitroglycerin patches, right? So, if they're on any patch, it can even be a Duragesic, a fentanyl patch for pain. If they're on any patch to kind of, to lower their blood pressure, that's going to make it harder for them to compensate. Okay, and then the last distributive shock that we'll talk about, and then we just have obstructive and hypovolemic, is the septic shock patient. So again, it's the different toxins, okay, that are released from the infection itself, they cause the blood vessels to dilate. The other thing that happens is it increases the permeability of the capillaries. This also happens in anaphylaxis. Whenever you increase the permeability of the capillary, it has the ability to leak plasma. So in anaphylaxis, you see that as the hive, that raised bubble that you see on their skin. So in sepsis, they can also get what looks like hives. It's just much larger areas. And a lot of times it's just, you see their stomach becoming swollen, and stuff like that. So they can get some leaky capillaries, which also can drop their blood pressure. Okay. So those two problems, the blood vessels dilating and the leaky blood vessels, is what drops their blood pressure. Okay, so the symptoms are all pretty much the same, okay, except that obviously, remember in the distributive shock, you get that priapism in the man, and you also get the bradycardia, which you're not going to see in any other shocks and stuff like that. Okay, so everything's pretty much normal, what we would think in shock, except that early on they may look confused, but it's rare that we see a septic patient early on. Okay. So that's that one. Again, intervention is going to be the same. Keep them warm, put them on oxygen, transport them to the hospital. Okay. Anaphylaxis is probably the one distributive shock that we could actually treat, because we do have the epinephrine. So we just have to recognize it. Most of the times they're going to get the epinephrine because of the respiratory component, but the epinephrine will cause bronchial.
Sorry, I'm having trouble hearing.
The epinephrine will cause bronchodilation, which will reverse the bronchoconstriction, will solve the breathing problem. Also cause vasoconstriction, which is the opposite of vasodilation, so we'll deal with the shock problem. So Epi is the treatment in anaphylaxis. The only problem we said is that because the heart may not be well oxygenated, it can cause damage. But again, we don't treat them, they will die, so you have to treat them and push your fingers and hope for the best. Okay. Remember, some anaphylaxis, most anaphylaxis occurs pretty quickly, within 15 minutes. There is delayed anaphylaxis that sometimes people get stung by a bee and don't have a reaction for hours. And there's also what they call latent exposure, where they eat something and they don't have, or they get stung by a bee, they have no reaction. Okay, I'm sorry, latent is that they have it again. So what can happen is they get treated, okay, they get the epi, okay, and then they get a second attack when the epi wears off if the substance that caused the allergic reaction remains in their body. And that's typically venoms, okay, and certain foods may stay in their body, or even like antibiotics may stay in their body longer. And the way we prevent that from happening is by giving those patients steroids, which means that every anaphylactic patient gets steroids, and that helps to ward off the latent phase of it. It doesn't help them in the emergent phase, but it prevents the second phase. Okay, so in anaphylaxis, obviously we have some airway problems. Okay, we have the skin problems. One of the keys to giving them the epinephrine is as soon as they tell you their throat feels different. My throat feels itchy, it feels tight, or you see their voice getting hoarse, anything like that, you can go ahead and give them the epinephrine. Okay. It's just skin symptoms. I wouldn't go ahead and treat them unless they tell you that every time they get anaphylaxis, they almost die. So here's the swollen lips. Right? This lady's got a little bit of the eyes, her left eye is closing and stuff like that. You see her neck is turning red. So she's probably going to move on to having some respiratory complaints. Hives appear in a lot of different ways. Sometimes they just almost look like some kind of skin infection. But this is, again, the increased capillary permeability showing. Right? So again, in vital signs, the blood pressure initially is normal. Okay, then it could drop. Once you give them the epi, though, it's usually high. They pulse rate again. Usually they're nervous and scared, so they get a little tachycardic. And somebody's radio is, I've lost the mute button here.
No, you're repeating yourself.
Hold on, I lost the mute button. Oh, that's me.
Yes.
Hold on.
Marty's here taking care of keeping that straight.
Okay. Okay, you're all muted, and who's ever not making a lot of noise, unmute yourselves. Okay, so the typically in anaphylaxis, they start with the tachycardia, but if they actually start getting slow, that means their heart is not being perfused enough, and that's a very ominous sign. Their breathing starts to be fast. They can wheeze, they can have stridor, okay? And again, the earliest signs is skin getting that red flushed if they're Caucasian. But if they move in this shock component, they're the Kupel and diaphoretic. Hives or urticaria is another sign. The redness is another sign and stuff like that. A lot of them will get headaches. If they ate the substance that's causing the allergic reaction, they usually get that gastrointestinal problems where they get cramping, feel like they're going to have diarrhea and stuff like that. So epinephrine is the only life-saving intervention. Benadryl will not save somebody's life who's in anaphylaxis. It may prevent somebody from going into anaphylaxis, although that's kind of dispelled. It may lessen the symptoms. It may help people who only have the skin symptoms. But if they're truly in anaphylaxis where their breathing is infected, epinephrine is the only drug that will save their lives. And so, again, if it's only skin symptoms, they don't usually need the epi. Okay? Oxygen, and in the new protocol, they put in albuterol also. I wouldn't use albuterol in lieu of epinephrine. I would use albuterol if you've given them the epi and they're starting to feel better, but they still have a little residual wheeze and stuff like that. Okay? So, but that's basically, the stuff. Okay, so now we'll go to obstructive shocks, and then hypovolemic will be done. So the number one obstructive shock is attention pneumothorax. We have cardiac tamponade, pulmonary embolism. So in attention pneumothorax, the way they go into shock, we know that the lung in attention pneumothorax, the lung has an injury and has collapsed, but every successive breath that the patient's taking, the air leaks out of that injury in the lung and fills the chest, right? Collapses the lung, but the pressure increases and starts to push across the mediastinum, the center of your chest. And if that pressure gets very high and it exceeds the pressure in your inferior and superior vena cava, it shuts blood flow off back to the heart. So that's why it's called an obstructive shock. So again, this is a situation where we really think the cause of death is breathing, but the actual cause of breath is shock. No cause of death is shock. Okay? So nothing we're going to be able to do on a BLS level except get them to the hospital quickly because somebody needs to stick a needle in the area where the pressure is to relieve the pressure. And we don't allow that in New York State. Okay? So that's what that is. And so I'm not going to go through everything here because I'm not really doing thoracic trauma tonight. Okay. I just had some pictures of, like this is this is the collapsed lung. It should be filling the whole thing over here. This is the CAT scan of what the collapsed lung looked like. The heart should be in the center, and you see how it's pushed all the way to the side. So all the blood vessels, especially the venous blood vessels that are bringing stuff back to the heart, get crushed and don't let it bring back. So you see jugular vein distension because it can't get blood back in. You see tracheal deviation. So the only place we could see trachea is in your jugular notch right over here, but I can't make it out well with all the bright lights on. But your trachea, oh, here it is. So it's coming down. It should be in the center of your neck. You see how it's kind of deviating. So this person has a left-sided tension pneumothorax. That's why it's all blacked out over here. They don't see any of the part of the lung like you see over here. You see how the heart is basically shifted all the way over onto his left side. So because of that, his trachea is deviated all the way over. But if you were to look up in his neck, you could see it's already starting to move towards the midline. So they really consider tracheal deviation to be an X-ray finding and something that we can't see without an X-ray by just looking at their neck. That's one of the classic signs. They can get subcutaneous emphysema, where they get all puffy, okay? And what do we do? So on a BLS level, if you can't decompress their chest, it's really just get them to the hospital. If they have an open chest wound, technically we're supposed to seal it on 3 sides. But if they get worse by sealing it, then you have to unseal it, right? Because sometimes what happens is you take a regular simple pneumothorax that has a hole and is venting the pressure and not allowing it to turn tension. And by sealing it, you actually turn it tension. So you could try to seal it, but if they get worse, you unseal it and stuff like that. Obviously, they need to be on oxygen. Okay, and the paramedics, if they come, they will do a needle decompression. I just put this picture in here because a lot of times when we think of the chest, we think of the chest as the front. But remember, your thoracic cavity goes all the way around, right, to your back. So this guy was stabbed repeatedly on his back. Nobody saw any other injuries on him. And they were kind of like, okay, you know, we don't know where all the blood's coming from. It's probably his head because he did have a pretty significant head laceration. And the guy wound up having a pneumothorax because, you know, he was stabbed in the chest and stuff like that. Obviously, depending, like somebody shot like this, I would think more of a liver issue. But your diaphragm, right, is usually about here. But when you inhale, it comes lower. So in this guy's case, okay, he didn't live. You could see his actual dependent lividity if you wanted to see what the dependent lividity looks like over here. But in this guy's case, it actually penetrated, I mean, destroyed his liver, but that's what his cause of death was, but it actually penetrated his diaphragm. He had a diaphragmatic hernia from that. Another cause of obstructive shock would be cardiac tamponade, and you learn that as a somebody like stabbed into the heart where the blood leaks out of the heart and fills the sac because the sac kind of self-seals. That's very rare. Most cardiac tamponade is medical, and it's caused by pericarditis, an infection. So most of it's medical, and most pericarditis present like a chest pain, heart attack patient. The only thing, if you really want to do a good assessment, so this is showing you cardiac tamponade. This is the pericardial sac, and it's usually touching the heart. So you don't see this big border. Because it's filled, in this case, with infectious fluid, you see it showing, and it's basically not allowing the heart to expand. So if the heart can't expand, the ventricles can't fill with blood, and the patient will ultimately die. But just going back to pericarditis, how you're going to differentiate and you can't 100%, and you're still taking them to the hospital, but maybe to hold off on aspirin and nitro and all that kind of stuff, or at least call medical control for advice. A pericarditis patient, it's an infectious origin. So first of all, it doesn't happen like that, right? It takes days to develop. There's a history of them being sick with a fever, okay? So they're febrile, they're warm. They have a history of some type of viral or bacterial infection, okay? And the other thing is they typically feel better when they lean forward. So you're gonna find them like leaning over the table, leaning over in the chair or something like that. Some of them feel better walking, but in general, if they shift their heart forward a little bit, they feel better. So, if you get that positional relief, not 100% relief, but that positional diminishing of the pain, and you have the history of the infection, it's probably more of a pericarditis than it is an actual heart attack, although a lot of the symptoms are very similar. Okay, so again, there's a lot of different things we can talk about, but there's the classic, what they call Beck's triad. Dr. Beck, picked out the 3 things that he identifies. So the blood pressure is low because the ventricles can't fill up. They get JVD because the venous blood can't empty because the heart can't expand, and the heart sounds become muffled because of the fluid around the heart and stuff like that. And there's EKG changes and stuff like that you see, but we're not going to be doing that on a BLS level. So here, technically, any hospital that has a cardiologist that can do what's called a pericardiocentesis, which is to take a syringe with a long needle and under ultrasound guidance, stick the needle into the pocket of fluid. So again, it's not usually like this where it's all over. It's usually pulled more towards the bottom so they could stick the needle and evacuate out the fluid. the patient would immediately improve. Obviously, it needs to be under ultrasound guidance because if you go too far, you stick it into the chambers of the heart. Years ago, they used to do it blindly. They used to stick the needle in the person's chest, avoiding obviously the lung, right? They had a specific angle. They went in from the front, avoiding the lung, and they pulled back on the plunger. And once they started getting blood, which again clotted up, infectious fluid type of stuff back in the syringe, they knew they were in the pocket. But now we do it with ultrasound guidance. It's just like, in the day they did an amniocentesis blindly, now we just do it with ultrasound guidance. Okay. Pulmonary embolism, we should talk about this briefly because this is probably the number one thing we see as far as obstructive shock goes. So basically, most pulmonary embolisms are a deep vein thrombosis from the leg that breaks free, comes up the inferior vena cava, and goes into the right atrium, goes through the tricuspid valve into the right ventricle, goes out the pulmonic valve into the pulmonary artery. And the pulmonary artery goes off the right ventricle and then bifurcates or splits and goes to the left and right lung. Usually when it hits that bifurcation, the saddle, the embolism gets stuck. And if it gets stuck there, the patient usually dies. They have what's called a saddle embolism, they usually die. The luckier people, it's a smaller embolism. It goes down either the right or left side and gets lodged down in the pulmonary circulation in the lung. And even though a pulmonary embolism sounds like a breathing problem, it's a blood flow problem where you can't get the deoxygenated blood down into the lung to get oxygen and get rid of carbon dioxide. The reason a lot of people think it's a breathing problem is the patient does complain of shortness of breath, but that shortness of breath is secondary to the fact they can't get the oxygen into their blood, not because they can't breathe the oxygen in. Okay. So that's the main way it happens as a DVT. You could get it from AFib. In AFib where the atriums are not contracting right? They're kind of just fibrillating. You can get blood that clots up in there, especially if you're not on anticoagulants. And if you throw a clot from the right side, it'll go right atrium, right ventricle, pulmonary vessels and cause a pulmonary embolism. If you throw the clot from the left atrium, it'll go left atrium, left ventricle, aorta, and go to your brain, and you'll have a stroke. So that's another way. In kids, a lot of times it's a long bone fracture, or it could happen in adults, but I'm saying it's rare for kids to have an embolism from other way, but they get a long bone fracture, they lacerate a blood vessel in the bone, and it causes an emboli. Sometimes women during childbirth can have an amniotic fluid emboli. So that's around the time of the delivery of the baby. Right after the delivery of the baby, they complain of sharp stabbing chest pain and shortness of breath and stuff like that. So DVTs are a big one. People that are bedridden get DVTs. That's why we always talk about this post-surgery bedridden patients and stuff like that. Atrial fib is another one. Women who are on estrogen-containing birth control pills and smoke are at high risk. Okay, or anytime you have inadequate blood flow. So any shocky patient, right, who has inadequate blood flow, can always throw a clot, right, because the blood is not moving, it coagulates and stuff like that. Patients who have aneurysms, aortic aneurysms, can throw clots because you get an artificial channel in the aneurysm and the bulge, and that could always throw a clot. COVID obviously is a big issue with clotting and stuff like that. So there's a lot of different ways people can get embolisms. But the classic sign and symptom is sharp stabbing chest pain accompanied by shortness of breath. We had a paramedic that just flew this was about a year ago. He flew from coast to coast, was fine, no problems whatsoever. Got off the plane, was walking to get his luggage, got sharp stabbing chest pain, got short of breath, and had a pulmonary embolism. He survived. You guys remember Dan Brady, right? So Dan was painting his home after recovering from various ailments and stuff like that, and had sharp stabbing chest pain, self-diagnosed himself with a pulmonary embolism and didn't make it to the hospital. Right, so it really just depends on how large of an embolism you throw and how much blood flow is being obstructed. Okay, the only treatment is to get anticoagulants or to get the blood clot removed by snaring and stuff like that. So they have to get to the hospital. Nothing that we could do in the field for those patients. Okay? So they have all the signs and symptoms of shock with the added sign and symptom of acute shortness of breath with that sharp stabbing chest pain and stuff like that. Okay, so there's nothing really we could do. So it's either anticoagulants or that snaring to pull it out. Okay, and then the last shock, and then we'll call it a night, is the hypovolemic shock. So you have two types of hypovolemics. Hypovolemic just means low volume. So you have loss of fluids in your body other than blood. Now remember, 60% of our weight is fluid. Okay, out of that 60% of fluid weight, only about 20% of that is blood. So the vast majority of fluid weight we have is what's called interstitial fluids. And we are basically a waterborne creature. There's water in every ounce of our cells. Our cells are floating in water. They're packed with water. And we cannot live without water. That's why, you know, the minute you stop drinking, you get headaches and you get dehydrated and stuff like that. So there's a lot of different ways it can happen, but the most common cause of getting shocky from fluid loss other than blood would be vomiting and diarrhea from a gastrointestinal problem. Right? You get a synthetic bug. Okay? And in kids, it happens really quickly. Very rarely people go into shock from sweating, but they can definitely have heat exhaustion, you know, which is a type of shock, but not life-threatening. Heat stroke is not actually the same. Heat stroke is where the temperature has climbed so high, it's actually injuring the brain and the other organs, but it's not actually a volume fluid problem. And people can have heat stroke without having heat exhaustion, right? In diabetic ketoacidosis, you know that the patient has the polyuria, where they have excessive urination, so they could also lose a lot of fluids. People who are dieting and using diuretics, or old people who maybe don't remember whether they're taking 1 or 2 doses. If you're taking too much diuretic, besides getting shocky from fluid loss, with that fluid that's leaving your body in the urine, you're losing a lot of potassium and sodium, so you could actually go into cardiac arrest or have arrhythmias from that. Okay, and then plasma-only losses is burns. Okay, so again, in a burn, it's technically a hypovolemic shock from fluid loss. Even though plasma is part of blood, they kind of lean towards the non-blood loss side when they categorize it. Okay? But they can lose a lot of fluids and stuff like that. Okay, so now we have the bleeding types, the external, internal. We talked about how we control the bleeding and everything like that. Most of the times, hypovolemic shock presents like shock like you expect it to. So they're tachycardic, they're breathing fast, they're tachypneic, their blood pressure initially is okay, but then it drops. Okay, their difference between their systolic and diastolic start to narrow. That's a very classic sign of hypovolemic shock, when the systolic starts to fall from the blood loss and the diastolic starts to rise from the vasoconstriction, and they start to meet, right? So normal pulse pressure, the difference between the systolic and diastolic is usually 40. We start getting concerned when it gets less than 30, okay? And when they really get shocky, it can approach 20. So you could have something like, you know, a blood pressure of 90, you know, 90 over 70, stuff like that. That's showing you the drop of the 90 down from, you know, the higher numbers is the loss of the volume, and the rising of the diastolic is showing you the vasoconstriction. And then when they move into the next stage, it starts to widen because they lose that vasoconstriction because, you know, the blood vessels are not being diffused. The skin gets the typical cool, pale, and diaphoretic. In the late, they get the mottled, where there's total lack of perfusion. Initially, they're restless, concerned, anxious. You know, help me. Why are we here? Why are we not going to the hospital? And then ultimately, they become unconscious. They all complain of thirst in this situation, whether it's blood or just fluids other than blood. Not that we usually measure urine output, but the urine output drops because they have antidiuretic hormones secreted by the body to conserve fluids, so they have decreased urine output. They have the least delayed capillary refill, although in adults we have so many capillary beds, that's not really considered a very reliable sign. So we do it more in kids. Their distal pulses get weak and stuff like that. So again, what do we do? So if it's external bleeding that we can control, we control it. Okay, and we talked about how to do that. All trauma patients, all, you know, really I would say all shocky patients should be put on 100% oxygen. I know with the cardiacs, we kind of shy away from it if their pulse ox is above 94%. But when you're in a shocky state, especially a traumatic shocky state, they need high concentrations of oxygen. Okay. The other thing they need when they're in a shocky state is warmth, right? They need to be kept warm. If you ever see the military manage a trauma patient that's being medevac, they put them in what looks like a sleeping bag. It's called a casualty care bag. And inside there's actually chemical hot packs that get activated. And, you know, the combination of the reflective bag and the heat keeps the patient warm. One of the interesting things with the COVID is that, you know, the government was distributing all this stuff. And we couldn't get gowns, we couldn't get face shields, and we could barely get N95 masks. They sent us a dozen of these casualty care bags, a dozen. Each one is like $150. If you go on the Northern Rescue website, you know, they're like $150. I'm sure the government doesn't pay $150. And, you know, we can't use them on a COVID patient. There's no need for them. This is somebody like you're doing, like you guys would use it if you had somebody on the Adirondack Trail that was hurt and shocky, and, you know, and you're going to take an hour or two to get them out. So So we gave them to, Medic 31, we gave one to, Medic 1 that has part of Harriman State Park, Medic 23. We gave them to those trucks to put in their backcountry bags. But, they're no use for a COVID or anything like that. Splint any fractures, okay? And if you can't split the individual fractures because the patient's unstable, you just put them on a longboard as a fracture management device. Okay, nothing by mouth in those situations. They need to go to a trauma center. Okay, so I am done with the night. Unless anybody has any questions, I'm going to unmute everybody. So does anybody have any questions about anything we went over or anything, anything we want to talk about? So I did make it to the 2-hour mark. So you will definitely get your 3 hours of credit by taking the exam. And Nancy, please don't call me up and yell at me about the exam. But anybody have any questions or anything?
Did I yell at you?
I'm afraid of you. So, I'm afraid you're going to call my wife up and rat me out. So, okay, does anybody have any questions on anything or anything else we want to go over? Everybody's good? Okay, so I will email out the exam to everyone. Well, actually, I'm emailing it out to like 2 people from Greenwood Lake, 2 people from Warwick, and 1 person from Pine Island, and then they're going to pass it out to everyone. Okay, and I will, once the video gets up onto YouTube, I'll post it if anybody wants to torture themselves again or anything like that. Okay, so everybody have a good weekend, and I'm going to sign off. Okay.
Thank you, Frank.
Okay.
Thank you.
Take care.